Let's call the public board meeting to action, and welcome everybody. Thank you for joining us. We have some apologies for absence this afternoon. So both of the associate Neds, Suresh Viswanathan and Tanuj Kapalaswamy send their apologies. Stephen Powis has also sent his apologies, but we're delighted to have Claire Fuller here deputising for Steve. And Jeremy Townsend, who is with us in this morning's private board meeting, can't be here this afternoon, so they've sent apologies. Can I just go to declarations of interest? Are there any changes to colleagues' declarations of interest since last registered? Thank you very much. Can I then ask for approval of the minutes of the board meeting held on the 5th of December?
Yeah.
Is that okay to take? Thank you. No amendments. Thank you very much. If I just start with a chair's update, what I'd like to start with actually is just recognising, giving personal thanks, and also thanks on behalf of the board to two of our colleagues for whom this is this is their last board meeting. So if I might, with Wal on my left, Wal Collada. So Wal joined the board of NHS Improvement in August 2018, and then the board of NHS England in 2022. Wal is one of the deputy chairmen, the two deputy chairmen, along with Andrew Morris. So actually, the end of March, actually, I'm stepping down, as are the two deputy chairmen. My huge thanks to Wal for unstinting effort on behalf of the board. The whole range of different committees that Wal sits on, predominantly audit and risk, but also NOMSCO, New Hospitals Programme, Chief Financial Officer Advisory Group. But the one I'd like to just focus on briefly and up front is, well, you chaired the new NHS England committee, which was the committee that oversaw the combination of NHS England with HEE, Health Education England, and NHS Digital. And that, following the fact NHS England and NHS Improvement had already joined, brought together at the top of the NHS in organisation structure over 24,000 people in the organisation. But if one thinks about it, it had to bring three substantive boards, all of whom had very busy agendas, real objectives and real obligations, statutory duties that they had to pursue. And we had to merge those along with all of the staff working together, and then to bring that into a concerted whole. And while you led that, and you led it with huge energy and diligence and real experience, actually, which you bring into us from the private sector, I would like to say that actually NHS England, with those entities within it, continue to operate, barely missing a beat actually in terms of its governance and its ability to focus and maintain the agendas of those, or the oversight of the agendas of those three entities. So you structured it really well. We also did the, again under your leadership, the very difficult task of actually, as we bring people together and we saw common functions, actually we were able to reduce the headcount of NHS England from over 24,000 people to just over 15,000 in that exercise. I think it is the singular most sizable public sector transformation, just in terms of those numbers of roles in one single exercise that actually were removed. As I say, that was done, and it saved over almost £500 million that was actually then redirected away from, if you like, head office and into the front line. It was a very difficult exercise, and you led it with consummate skill. Step away from that, I would like to thank you personally for your huge support as Deputy Chairman. You, with Andrew and me, meet very regularly with Amanda and Julian, and continue to do that outside the rhythm of the board meetings. So huge engagement. I know colleagues on the board give you their deep thanks, and actually will miss you. So thank you, very much. If I can turn to Andrew now, Andrew Morris, the other Deputy Chair, in very similar start point, I think. So different experiences from long back, but actually August 2018, you also joined the board of NHS Improvement, and then in 22 joined the board of NHS England. And you have been an absolute tower of strength on the board. Andrew, the amount of stuff that you do for the board in terms of the committees that you sit on, and people don't often see the amount of work that's done by a board in its subcommittees to make sure that all of the agenda items are covered. And so, Andrew, whether you sit and you chair WTEC, so the Workforce Training and Education Committee, you sit on PRC, you sit on New Hospital Committee, you sit on CFO Advisory Group. You also have been the FTSE Guardian champion, you've been our maternity champion, and actually one of the most demanding calls on your time has actually been when you sit and you chair the board-to-boards in the RSP, so our Remediation Recovery Support Programme that we run with those trusts or ICBs which are under the most pressure. And I think you chair 80% of those meetings, and Andrew, so huge thanks to you. And also on a personal level again, you know, working actually as a triumvirate with Wallen, with me, and I think it's been quite a happy triumvirate. I say that, but I've got the microphone, so that's all right. My personal thanks to you for all you've done. I say that, and then it's also you get the chance to hear your obituary early, because there is some conversation ongoing, as you know, with the Department of Health. So we're exploring with the Department of Health whether there's a short-term extension for you, which we quite like to achieve if we can, to help manage the transition and frankly ensure continuity for the work that you are leading on behalf of the board. And that's as we process through, one, the attraction to the board of new non-executives and clearly also a new chair. But Andrew, so it may well be that you stay for a shorter period beyond the end of March, but that doesn't stop in any way my thanks to you on behalf of the board for all that you have done. Let me go on and just very quickly cover a few highlights only in relation to my own activities since the last board. So actually since the last meeting, Andrew and I have joined twice weekly winter assurance calls with Sarah Jane, so receiving reports back on how actually the NHS has been handling winter and where the pressures were and the particular pressures and then the responses to them. Forgive me, I've been continuing a personal focus on frailty, so on the frail and elderly. So I went on last week to the Black Country, and I went to the Midland Metropolitan University Hospital and also met the Black Country ICB, where we had it was a very insightful visit actually, and their engagement, particularly in the Sandwell Frailty initiative, clear clues, I think, as to how we might improve our engagement for the benefit of the smooth running of the NHS, to improve our engagement with frail and elderly patients. And then on Monday I was at Eastbourne District Hospital, again also with the Sussex ICB, and again most of the focus of that day was on frail and elderly and what are the options and what are the potential choices we could make in terms of how we change our offering. I had a very interesting meeting with a professor of economics at the London Business School, Professor Andrew Scott, who actually has a high focus on longevity, and that's a key founder of the Longevity Forum. So again, it was part of me trying to improve, forgive me, my personal understanding of the challenges in offering proactive care to our elderly and frail. I usually update the board on genomics. Let me do that very briefly. So there have been a couple of board meetings, Genomics England board meetings, where I attend the board with Sue Hill, Professor Sue Hill. And actually Amanda and I we also had the pleasure of attending the NHS Genomics Medicine Service Summit in December, which was led by Sue. And actually it was that presentation you made actually at that summit, Sue, that prompted us to think, would you come and do the presentation today? Because it's very interesting just to see the extent of progress and also the extent of ambition we have for genomics. I think it is that we would anticipate that in 10 years' time, 50% of health interventions will involve some form of genomics analysis or genomics analysis. Now, as a board, we've discussed the 10-year health plan. Last Friday morning, the board met to have a further update with the 10-year health plan team. On a personal note, I've had a very good couple of sessions with one of the co-chairs to the physical infrastructure working group, essentially discussing with him what potential plans might emerge in terms of a 10-year plan with regard to the NHS's physical infrastructure. I also attended a public deliberative event in London where Andrew Gwynn, the Minister, was the lead for government, and I was struck actually just by how engaged and what a good set of discussions was held in the room. And I'm going up later this month, actually next week, I think, to Birmingham to join a similar event, but for staff, for NHS staff, which I think is in Solihull. Last week we published the planning and operational guidance for 25-26, which does see a significant streamlining of priorities and measures of success, and that's to help us focus on what matters most to patients and also giving local systems greater flexibility to use their funding allocation to best meet the health needs of their local populations. And I know, Amanda, that you'll address that in your words, I'm sure, and Julian probably also in his. And then just a couple of meetings, so one with the Academy of Medical Royal College presidents, and separately a meeting at the department with other health ALB chairs, where the Secretary of State also came. And we had a very helpful conversation, mainly focused actually around the 10-year health plan. Now, I am going to ask actually for the board to humour me a little bit, because I would like just to reflect on actually Amanda, what you and your executive team actually have been delivering over the last 3 years or so. I do that because this is my last board here in London, and actually I think it's really important that, almost for the record actually, that we recite just the extent of the delivery, Amanda, which you with Julian and Emily and the rest of the executive team around this table, what you have achieved. And forgive me, you can try and stop me, but I often describe what you and your team do as really excellent operational and managerial delivery. It's operational and it's managerial, and it requires real focus. At the same time, you have to engage wholly appropriately into Whitehall, into the Department of Health, more broadly into Treasury, and to handle the perfectly sensible, often and appropriate requests we get from our Secretaries of State. But what I really focus on is just how much delivery you and your team have achieved. So if I gave some background and thought first of all about the fact that I think the NHS today is providing absolute record volumes of healthcare. Record volumes of healthcare into the population. So it's whether it's actually just some recent stats, whether it's the fact that last year there were almost just under 380 million GP appointments, primary care appointments in England. And if you think what that represents, it represents the equivalent of 1 in 7 of the population having an appointment in primary care every single week. And more to the point, it's 60 million more in a year than it was pre-pandemic. So huge thanks to our primary care practitioners, our GPs, just for the sheer amount of patient support that they are providing. In cancer, last year, there were 3 million cancer referrals. That was 27% up on 2019. In fact, and it was more than double the number of cancer referrals and diagnoses that were actually carried out only 8 years before that. So we are identifying, as Peter Johnson often says, we're identifying cancer earlier, and that's helping us get treatment to people earlier. We clearly still need to do better on constitutional standards, but 3 million cancer referrals, last year, remarkable. If I then think about what we've just seen in this winter, so we'll talk about it later on. The NHS, throughout all of its operations, has handled, I think it's 7.4% higher volume than the winter before. So in the winter 24 to the beginning of 25, compared with 23-24, we've seen over 7% higher volume in terms of patient presentations, and have handled that. And we'll hear later on, I think we've handled that actually really strongly. I know we can do better, but actually we're handling ever greater demand and holding to standards, if not slightly improving them. What about delivery? Just a few things. So community diagnostic centres, a foundation actually for the government's recently announced focus on increasing and improving diagnostics. So in the last 2 years, the NHS has doubled the number of community diagnostic centres from 89 to 180. We've rolled out same-day emergency care, SDECs, which now operate in about 88% of our trusts, a huge increase in the rollout of that capability over the last couple of years. Urgent treatment centres, the same. You then go to virtual wards, and I just said this morning, we talked about virtual wards a little bit, and for me, it's a very brilliant step forward for the NHS, although I'm frustrated that we stopped where we stopped. So when I first was appointed, it coincided with an announcement that we were going to roll out between 40,000 and 50,000 virtual wards, hospitals at home. And actually, we started a little slowly, but then we built them out really fast and staffed them really fast. And what they are, of course, is technology-based monitoring of patients, essentially at home or in a home. So it's exactly in line with the shift, which is to move care out of the hospital into the community. And then we stopped at 12,400 virtual wards. And we stopped for a variety of reasons. But if it were my personal choice and we had the resource for it, then I actually would continue that programme. And whether 40,000 is the right number to get to, or whether it's 30,000, personally, I certainly feel it's more than the 12,400. But the important thing, Amanda, is that you and the team built those out, and we saw real benefit. I think they operate about 85% utilisation. What else? I mean, that sounds quite a lot, but the first long-term workforce plan produced a couple of years ago, first long-term workforce plan in 75 years history of the NHS. We did a long-term capital plan called the Long-Term Infrastructure Strategy, not published, but given to the department and given to the Treasury. It was based on properly sourced foundational fact base about the physical estate that the NHS operates through. And I do think it's a seminal document actually for the Physical Infrastructure Working Group that I was referring to earlier as they looked to the 10-year health plan. So that was produced. We certainly shouldn't forget, because it's a seismic change to the way the NHS operates, but the ICBs emerged actually in July, almost 3 years or so ago now, and they are a mechanism for devolution of health closer to the community and closer to the local population. And in many cases, they're showing excellent steps forward. Some have more challenges, but actually the ICBs have emerged in that period. And I referred separately to, while this was all going on, actually NHS England was combining with Health Education England. NHS Digital had absorbed NHS Improvement, and we shouldn't forget NHSX, and was actually reducing its workforce by 35% and continuing to manage all of those board agendas. So significant exercise of restructuring and merger in that same period. I did say you'd have to humour me. I did an interview recently, in fact yesterday, and I was asked what had surprised me when I came into the NHS. And one of the things I said was actually I was surprised by just how innovative it is. And I hadn't realised just how innovative the NHS is. So whether it's in genomics, where last year we did 800,000 tests, either whole genome panel or single tests, and we've now scanned for 200 cancers, 7,000 rare diseases. Remarkable. And we're one of the world leaders. We've started the newborn program in genomics, and we finished and completed on the 100,000 whole genome project. Last year, cancer vaccinations, cancer vaccine platform, liquid biopsies, absolutely remarkable. AI, we use AI. We've been using AI for a number of years in screening and scanning, whether it's for breast cancer or brain scans. We use it in dermatology. We use it in ophthalmics. So we're using AI as a new way to deal with volume scanning. And actually, that's been running for some time. And then actually I've had teachings on robotics and nanorobotics. So nanorobotics, which are capable of single cell cure or single cell or a brain aneurysm, it's not generally available, but we now have the potential and have achieved that. Imagine the innovation that is promising for the future. But going back to the cancer vaccine, I have often said, actually, having heard about the cancer vaccinations that we gave for bowel cancer and lung cancer last year, we can now conceive a world where actually we could see cancer vaccination as a fourth armament with which to fight the scourge of cancer, so that we use surgery and radiotherapy and chemotherapy. But imagine, and we can conceive it, that for a number of cancers, not every cancer, but for a number of cancers, we may well have a new armament, actually, which would be vaccination. And then I'm going to talk about technology. The NHS app now has 35 million subscribers. It has much improved functionality. It is transformational to where the NHS interacts with the population and society. And there's much more that we can do, and it can be used essentially partly to rationalise and drive through in connection to legacy systems, but also we can improve its functionality and what it offers patients in terms of their engagement with the NHS. The Federated Data Platform was awarded about a couple of years ago, a very significant procurement, and the FDP is a translation layer that sits across all our hospitals, all our secondary data, and allows us to translate their data without them all having to recode their underlying machine code. So again, the NHS app, FDP. When I first arrived, I remember Amanda and Julian and others, Amanda Doyle and others here, talking about our primary care practices and just some of the basic problems we had in telephony. So actually you invested in and rolled out digital telephony, which now is in 98% of primary care practices. And it is a major step forward in improving access, but actually it took investment, it took decision and prioritisation. Electronic patient records now in primary care and or in hospital trusts. Remarkable growth in electronic patient record take-up throughout our, as I say, primary care and our trusts in the 90%, high 90% in terms of EPR now being operational. Now we've got to make them connect better, but the first step is there. It's followed real focus. And we still now, with VIN, we look at ambient documentation where we are essentially voice to text, potentially saving 30 to 40% of a clinician's time, improving the interaction of the clinician with the patient in terms of the quality of that engagement, and you're running a number of pilots in that. So you look at innovation in technology, I mentioned earlier in terms of genomics and in cancer vaccine, and it just goes to show the NHS is innovative and continues to change and continues to improve all the time. But we still have to fix our basics. We absolutely understand that we have to fix our basics. But Amanda, to you and the team, what you have delivered, I think, in this period that I've had the privilege of being alongside you, I think is remarkable and is often missed. And you deliver that through operational, managerial focus. And you've also delivered it, whilst Julian, my compliments to you, balancing the financials, which is a huge task with lots of different pressures, where it's been managed in a period where we've seen substantial industrial action and some periods of steepling inflation. So actually to handle the numbers and to produce the performance that you have against that background, I think is even more remarkable. And then there are just two other things I would refer to, but only very briefly, and they are a couple of pilots, and they're actually on the agenda we had this morning. So one is the primary care, I call it a pilot, but it's the primary care exploration of new models to operate, where Amanda, you and your team are engaged with GPs, looking at how can we help, what's such an important part of the NHS, taking and managing a lot of the risk for the NHS, our GPs and our primary care practitioners, are the better ways that we can help them run their practices. And then separately, there's a frailty pilot. There's a frailty and elderly pilot. We discussed it again in the private board. It's on the agenda for this afternoon. And the board will know from our earlier conversation, I think that is one of the, if it were me, one of the most important areas on which we should focus in the 10-year health plan in terms of what should we think about implementing first that would have most impact upon a relatively small cohort of the population, but a high intense utilisation of our capacity. So it's the frequent flyers or the intense users of our capacity are, in many cases, are frail and are elderly. So, Amanda, I wanted to list, and I'm sorry for that, for being a little bit tedious, but I sometimes think that what you and your team have delivered over the last 3 years, actually, I mean, it's just worthy of reflecting on it, actually, really worthy of reflecting on it. I think it's a huge delivery agenda that you have achieved, so thank you very much. Now, at that point, and before you even respond to that, which you shouldn't, I'd like you to run on to the Chief Exec's update, but there's no need to comment on anything I've just said, but if you would just like to give us your CEO's update, that'd be great.
Thank you very much indeed, Richard. And I recognise everything you've just said, but I know you've said I don't need to respond, but I would like to just add, if I may, 2 things. One, anything that we have achieved is because of how we work with partners and colleagues, and particularly NHS staff and the leadership community within the NHS. So the credit is theirs. And 2, we all know and have discussed extensively as a board that despite everything you've said, things are not nearly good enough for our patients. So that is why we are really ambitious about scaling up and spreading what's worked best in parts of the NHS over recent years, lots of which you've described, and working with government as they develop the 10-year health plan to set out how we will radically transform the NHS, building particularly on the opportunities we now have with technology, with data, with life sciences. So on behalf of the executive, I'm really conscious you don't want me to say what you have said again, but it would be remiss of us, I think, not to just thank Wal for his time as Deputy Chair, because Wal's support from my executive colleagues, I know, has been enormously appreciated, as well, Wal, as the extensive experience that you have brought us from the private sector and elsewhere. And, as you said, the amount of effort that, Wal, you've put into the new NHS England programme, and thank you particularly for that. I'm conscious of what you've just said about a potential extension for Andrew, but just in case I don't have the opportunity...
He's like the Windmill Theatre, he never closes or something like that.
I would just also like to make sure that we have properly thanked Andrew, again on behalf of the executive, for the expertise that, Andrew, you have provided on the board of NHS Improvement and more latterly NHS England. But those are obviously just the most recent years of what has been a distinguished career spanning 5 decades, and I think it's fair to say there are few who have made the kind of mark on the NHS that Andrew has, and we would be poorer, will be poorer, without your wisdom. So let's hope we don't lose it too soon.
Can I just also, I'm going to come back because you're quite right to, and I'd like to pick up the emphasis and just say, in spite of that list of achievements, we do absolutely recognise we need to get better in a number of our basic provisions. And secondly, you're quite right. You know, I have the privilege of going out into the front line a lot, and people host me a lot, and I always come back. One of the best parts of the job I've been asked to do actually is the ability to meet the front line, and not just the front line, but the managers throughout our system and our frontline staff who are passionate and committed, and I think carry a huge burden and do a great job. So thank you for reminding me.
Thank you, Andrew. And on that very note, it has been a couple of months since we last met, but I did want to start by talking about the report published yesterday by the Midlands team into the care and treatment of Valdo-Calais by Nottinghamshire Healthcare NHS Foundation Trust. The first thing to say is that my thoughts, our thoughts, continue to be with the families and loved ones of Ian Coates, Grace O'Malley Kumar and Barnaby Webber, who have all suffered just heartbreaking and immeasurable personal loss. The report confirms that the system, including the NHS, failed Valdo-Calais and therefore failed Ian, Grace and Barnaby, and I want to add my full apology to the families for the unacceptable failings by the NHS in this case. The report helpfully sets out a number of recommendations for the Trust, the ICB and for NHS England, which we will be taking forward in addition to the actions that have already been taken over the last 18 months to improve how those services work. But as ever, we are clear that where there's learning for one system, there will be learning for others. So we've written to the whole NHS to urge colleagues to read the report and develop their own action plans with their local partners, including the police, to better manage risk for patients with severe mental illness. Again, that's on top of actions we've already taken at an NHS-wide level, particularly on how services manage patients who disengage with care. Lastly, it's worth saying that we heard the concerns shared by families about the approach to publishing this report, and I apologise for any upset this caused. When you're talking about people's medical care, there are complex legal and confidentiality issues to navigate, especially in sharing more widely than with the families. So what this case reinforces is the need for us to work with the Department of Health and Social Care and partners to agree how future independent mental health homicide reports should be published to ensure that we comply with our legal obligations whilst also being transparent and supportive with affected parties. I know, Richard, that's one we're going to want to come back and talk about more, but it's immediate. With the reports only out immediately, we don't have a substantive item on the board today. No doubt we'll want to for the next meeting. If I may move on, the other thing, of course, since we last met, is the NHS has faced a very challenging winter, with a particular impact felt from higher than usual levels of patients hospitalised by flu, norovirus and RSV, as well as COVID. So combined with discharge delays, that has meant capacity has been stretched, leading to flow issues manifesting in trolley waits and ambulance handover delays. Our national and regional teams have been working intensively with systems and providers to tackle those issues. Again, thank you to them and to all of the hard work that colleagues have done across the NHS, and I'm sure we'll discuss that work in the section on operational performance. But as I say, on behalf of the board, I do want to say a huge thank you to everyone who has been working so hard to deliver the safest possible care in some really very challenging situations. Alongside that operational challenge, we've been working intensively over the past couple of months with the department to square the budget settlement and the wider impacts of the Chancellor's autumn budget with government priorities for delivery. So firstly, that was to be able to update the system on in-year adjustments as we enter Q4, and secondly, to agree and publish the operational priorities and planning guidance for 2025-26, which, as Richard says, we did following the laying of the government's mandate to the NHS, to NHS England in Parliament last Thursday. I won't go through it all in detail here. We have discussed it as a board, but suffice to say that we've put a huge amount of work into making this planning guidance look and feel markedly different for the wider NHS as part of our broader direction of travel towards systems having a greater degree of autonomy alongside clear accountability, and with support from NHS England within a clearer operating model framework. So what does that mean in practice? Four things worth pulling out. Firstly, it means giving systems greater freedom to manage constrained budgets, transferring a higher proportion of funding than ever before directly to local systems and minimising ring fencing, allowing local leaders maximum flexibility to plan better and more efficient services. Secondly, and reflecting the mandate from government, we have significantly honed down national priorities to increase local autonomy. Thirdly, as we set out in one of the annexes to planning guidance, we are streamlining the planning process itself, providing more practical support, asking for fewer returns, and giving space for systems and providers to engage more thoroughly with each other and their local partners to develop plans which are deliverable and which everyone is signed up to. And lastly, the annex I just referenced also sets out that at the end of the planning process, we will agree a compact with systems which sets out what each organisation will do and the support they will get from NHS England to deliver. Three other things, if I may, just to mention in relation to planning guidance. Firstly, and quickly, we publish guidelines to support local systems developing neighbourhood health services. So that's work that this board and that you personally, Richard, have championed strongly over your time as chair. And there's an opportunity to discuss that more when we get to the agenda item on supporting people living with frailty. Secondly, key to the support offer is our delivering on key pieces of work over the coming months. That includes the NHS Improvement and Assessment Framework, but also our approach to financial incentives for organisations and individuals, how we support our most capable leaders to take on challenged organisations, and more broadly, how we upskill colleagues at all levels to drive clinical and operational improvement. And thirdly, it's about what that means for NHS England as an organisation. So just a couple more things I want to talk about, but I do want to just spend a moment, if I may, on NHS England. Yeah. So at our last board meeting, I talked about how, as we develop a new operating model and give greater autonomy to systems, the role and size of NHS England would reduce. In the planning guidance, we are taking the next steps on that journey, but at the same time, we're asking the front line to make difficult choices about where they prioritise finite resources. So, we should not exempt ourselves from that same challenge. So it's with that sort of twin ambition of both maximising, and you talked about this a moment ago, Richard, but maximising the amount of NHS funding which reaches the front line, and continuing to change our organisation so that we're more clearly focused on where we add value, so in line with our operating model, and where we support frontline delivery in line with the government's priorities. So what that means in practice is that we're going to be taking a good look at some of our functions and some of the ways that we work as part of our planning process for this year. And it means we're setting out explicitly with the aim of delivering more savings to support the front line over the coming year, and that's on top of the recurring benefits from the new NHS England programme. And we've set ourselves the ambition of saving 150 million of non-pay resources and reducing our staffing costs by another 175 million. So that is the equivalent of about 15% of the new NHS England structure. On our staff call earlier this week, Steve and I acknowledged that this comes really pretty quickly after the new NHS England programme, which was a very challenging process for lots of us and lots of our colleagues. And we said, I think explicitly, we absolutely recognise change can be tough, even when it's for the right reasons. And fundamentally, we are all here to make a real difference where it matters most for patients. But all of us, I think, around this board table and certainly in the exec group, are very clear we need to do that at pace so that we can give people clarity. And that's what we'll be doing in the coming weeks, with national and regional directors working together to identify a first draft of which functions we should make targeted changes to, because that's the crucial point here. It's got to be targeted in order to deliver the ambitions I've set out. So we can then discuss as a group after that, and then give directorates and teams feedback as quickly as we can about the broad shape of those plans. So in the meantime, we're going to give everyone the opportunity to share their thoughts and ideas on where NHS England adds the most value to the NHS and where it can be strengthened further, but also where we add less value and where we duplicate work and where there are things that we need to do in a different and more effective and efficient way. So we will, and I think, again, Steve and I told colleagues this very explicitly when we were on the call earlier this week, but we will continue the important work on our culture. So we're not pulling that back at all, and we're continuing to do the work on developing our internal ways of working and also on developing people's skills, so alongside that change. Other developments, I promise I'm on the home straight now, but I did just want to briefly mention a few other developments since we last met. So you've referenced it already, Richard, but around a month ago we launched the elective reform plan, setting out the interventions agreed with government, which will contribute to meeting the manifesto commitment and priority to return to the constitutional standard on 18 weeks by 2029. That was a very important moment for us, because I think it encapsulated what I said earlier about really wanting both to build on what's working really well in some parts of the NHS, but also a real commitment and evidence of us now taking those important first steps in really transformational change. Earlier this week, on World Cancer Day, the department also launched a call for views from the public on priorities for a new cancer plan, which is due to be published later this year. Again, I just wanted to share with the board at this point that Dame Callie Palmer, who is the National Cancer Director at NHS England, has announced to her team that she will be stepping back from the role after nearly a decade of service. Callie's led the implementation of a number of previous plans and been absolutely pivotal in transforming and accelerating cancer care in England. At all times, she's ensured we focus as much on how those living with and beyond cancer experience care, as well as how the NHS can deliver more of it. And on her watch, the NHS has delivered a huge expansion in the number of urgent cancer checks delivered every month, contributing to more cancers being caught at an early stage and the highest cancer survival rates in England's history. Loads more to do, and we really welcome the launch now of that call for evidence and the commitment to a new national cancer plan, but we're immensely grateful for the contribution that Callie has made nationally and of course will continue to make as Chief Executive of the Royal Marsden. And lastly, I wanted to highlight a couple of the announcements we've made recently in case people hadn't fully clocked them. The first is the fact that the NHS Jewish BRCA testing programme, which was launched 2 years ago, has now processed around 11,000 at-home saliva tests, with 235 people testing positive for a BRCA gene mutation, which increases the risk of breast, ovarian and prostate cancer, enabling them to seek early access to screening and preventative options, and of course thousands of others given reassurance that they do not carry the genetic risk. And secondly, we were able to announce that we've reached a deal to make a revolutionary gene editing treatment available for people with a severe form of sickle cell disease, which trials concluded provides a functional cure for more than 96% of patients. And I share those because they are a good reminder of the impact of the work we do here on behalf of the NHS that brings real benefits to patients, and examples of some of the really transformational things that we can and are still really ambitious about for the future. And I know we'll be hearing a lot more about that later on when we get on to the presentation on the NHS Genomic Medicine Service.
Amanda, thank you. Are there any comments, questions, reflections to Amanda? Well,
just do one. You probably expect me to comment on the further restructuring that's going to be going on. You talk about the support and ongoing work around culture, which is one of the sort of bits of unfinished business that we left post the new NHS England programme. So that's the first thing, just sort of maybe amplify that a bit more, because I think that's going to be really important, giving colleagues reassurance that has been done. The second thing is that, again, if we're going to reduce numbers even further, then just giving colleagues the assurance that it's not about squeezing more out of them, it's about what are we not going to be doing. Thank you.
Thank you. Well, I'll let Steve come in on the culture work, because Steve's been leading that within the organisation. But just to say that has actually come across really strongly, even from initial feedback. And I think we are absolutely clear that that is what we're talking about here. We are talking about stopping stuff, not trying to just have fewer people do exactly the same amount of work. But Steve.
Thanks, Amanda, and thanks, Wal. So that you'll remember, partly coming out of the new NHS England Committee and then into the People and Remuneration Committee, we developed the OD plan for the first couple of years with a heavy focus on developing line managers, so new sets of appraisal tools, giving feedback, and a 4-module line manager development programme over the course of about 6 or 7 months. Module 1 of that has run. It was run up to just after the beginning of January. Module 2 is about to start, and we've said that we're working with an external partner on that. We've said that will continue alongside all of our other work on development and inclusion and so on. So we're not changing the plan. It's kind of steady as you go, and we keep going with it.
Any other comments, reflections? Okay, so I'm going to move us on in the agenda, and when we look at the agenda, we can clearly see that we're going to have the update, the normal update from Emily and from Julian on finance. We're going to look at NHS productivity, children and young people update. We've got a presentation on the Genomics Medicine Service, Sue, and also we're going to have a look at transforming the Frailty pathway. And then there's some delegations we're going to do around some of the commissioning functions, which are a further important devolution, or delegation, into the ICBs away from NHS England. And this morning's board, the private board, we also had very good reports from each of the committees that oversee the underlying work of the NHS England board. So Digital Data and Technology Committee, Workforce Training and Education Group, the Quality Group, the CFO advisory group, and then People and Remuneration Committee. So we had those updates showing actually the substantial work underway in the intervening period between when the board itself meets. We also had an in-depth discussion, Julian, led by you, actually looking forward into next year's financial position and planning, and also the planning guidelines and their interaction. So let's get on with this afternoon's public board agenda. So Emily, can I hand to you for an operational performance update?
Thank you, Chair. So today I'll take you through our performance across elective recovery, cancer, diagnostics and mental health. I'll turn to Sarah Jane for an update on UEC and winter before just offering one thought in closing before we go to questions. I think my key message, as with I think probably the last 4 boards now, I'm trying to remember, is, as you and Amanda have already reflected, the NHS is doing extraordinary things in delivery every day and looking to improve services and innovate, and we have huge distances still to cover to make sure we are absolutely delivering the services we would like to deliver at the quality we'd like to deliver every day. So I'll try and pull out some of those challenges as I go through. Firstly, on elective care, the good news is that the total wait list is reducing. Between October and November, it fell by over 61,000 patients to 7.48 million, which is lower than the 7.6 million this time last year. Long waits are reducing, and we continue to see improvements month on month. For example, 78-week waits from October to November were down 16% to 2,051, and 52-week waits were down 5.5% to 221,889. But as you can tell from those numbers, we need to continue to innovate and improve. And of course, as signalled in the elective reform plan and in planning guidance, the system is now pivoting to focus on the target to return to the constitutional standard on referral to treatment by 2029, and the target for 25-26 to deliver 65% of patients waiting no longer than 18 weeks for treatment by March 26. So our regional teams in particular, supported by the national programme teams, are working trust by trust, speciality by speciality, to drive delivery through targeted interventions that improve patient experience and deliver the timely, high-quality care that is our collective ambition. On cancer, all 3 of our cancer standards have improved in November when comparing year on year. The faster diagnostic standard hit 77.4%, which exceeded the target, and is up 5.6 percentage points from 71.8% in November the previous year. 62-day performance improved to 69.4%, which is a 3.9% percentage point increase on last year, and is on track to meet the 70% target by March 2025, on the way to recovering the constitutional standard of 85%. 31-day treatment standard is effectively stable at 91%, which is up from 90.2% in the previous November. On diagnostics, we are delivering more tests than ever. Nearly 2.44 million diagnostic tests were carried out in November 24, which is up from 2.38 million in October. The waiting list for diagnostic tests is now 1.615 million, with 6-week wait performance improving to 19.9% from 23.3% in November 23, which is the best position since March 2020. But we have to maintain the pace on this. We are, in diagnostics, barely keeping pace with demand growth. And as the board will be well aware, diagnostics underpin elective recovery, including cancer diagnosis. So we're working closely with systems through the planning guidance and beyond to sustain high levels of productive activity and to make sure that the considerable additional capacity that has been funded is being used to best and most effective effect for patients. On mental health, I think the summary would be we are continuing to expand access, but pressures remain. On perinatal and maternal mental health services, for example, we saw a 12.9% increase from last year to 55,561 in November 23. We saw for children and young people accessing services, that was up 6.4% year on year, although we are really conscious that that's mixed across pathways. So the children and young people's eating disorder pathways continue to be challenged. So for example, 83.3% of urgent referrals were seen within 1 week. That is an improvement from October, but still a way short of the 95% access and waiting time standard. And finally, an area enables me to transition to Sarah Jane, mental health 12-hour waits in A&E remain too high, with around 1 in 5 mental health patients experiencing a long wait in A&E. So on that note, Sarah Jane, let me turn to you for an update on winter and then I'll finish off.
Thank you, Emily. Yeah, so as Amanda and Emily have both referred to, it's been a challenging period for all of our colleagues, I think, across health and social care. Obviously, the winter respiratory virus peak comes every year, but we're never exactly sure when that's going to be. And this time, it came to perfectly coincide with the period between Christmas and New Year, which I think added to some of the challenges that we faced. At its peak, we saw 5,800 patients in hospital with flu, and the highest figure that we'd been at in the previous year was 2,500. So it was a shorter, sharper peak that brought with a huge range of challenges. At the same time, we also had significant norovirus, and in fact that is continuing now to be a challenge for many of our clinical teams. The response of everyone in the system was remarkable, clinical and operational leadership. Though we were in the holiday period, it did feel for many of our teams right across NHS and care there was little time for holiday because everybody was all hands on deck really working throughout to keep patients safe. And we used, at the system level, our system gold meetings and proactive use of critical incidents for short periods of time to help organisations and systems to absolutely prioritise on that decongestion of the front door and be able to get services flowing again. I think some of the things I would just like to point to as things that I think went quite well for us, and then I'll just say a few things about the challenges before handing back to Emily. I think the things that worked particularly well were 111. Normally over a winter period we often hear concerns raised about 111. It held up remarkably well. It did an additional 267,959 clinical assessments compared to the previous year, and we know that's massively helpful because if people get that conversation with a clinician, they are more reassured about the next steps in their care. That meant that only 3.5% of people that contacted 111 over the period abandoned their call, compared to 10.5% in 2023 and 40.8% in December 2022. If 111 works well, that can become the bedrock of how the rest of the system then builds around it. So I think we need to acknowledge that that was a really great performance from a range of services. We also saw a huge step up from our ambulance services in terms of the delivery of the left shift, so using hear and treat and see and treat really effectively to not take patients to hospital unless it was absolutely necessary. And part, Chair, you quoted the over 7% increase in incidents, and part of the way we were able to manage that was to give that advice either over the phone or face-to-face in people's homes and not need to take all of those patients into hospital. We also managed to get our bed occupancy down to 92%. We set ourselves that as our standard, and we achieved it in the days leading up to Christmas Eve, and we had more of GNA beds open over the period as well. And I think the thing we know from when we talk to patients and families, that the most important thing of all that we're able to do in UEC is to bring an ambulance when you really need one. And although we did have a couple of individually challenging days, we had 2 individual days where our performance went over an hour for category 2, which is a significant improvement on previous years. And although we did have a couple of challenging weeks when we were in the sort of 40 minutes, we really were able to recover our performance quickly and get back down to around the 36, 37 minutes that we are running to at present, which is still too long, but I think is something that we all feel is a priority to focus on. Part of the way that we delivered that, though, was to really be very flexible about the way that some of the front doors of our organisations worked. And lots of hospitals were very, very full in the emergency departments, in the medical assessment units, in the wards, and unfortunately, in instances, in temporary escalation spaces. And our 12-hour, whilst our 4-hour performance continued to be better than last year, our 12-hour performance is the thing that we really need to focus all of our attention on. I think as we go into the year ahead, I think we know for some of those patients, it's not only the waiting, which nobody wants to do, but the experience of doing that in temporary escalation spaces can be poor. And Duncan and team put out some guidance to systems, which I know lots of people found helpful. But I think we've still got more work to do there to absolutely ensure that we maintain the safety and dignity of patients if we're not able to admit them in a timely fashion. So hopefully we are through the other side. We have weekly meetings with the UK HSA and the signs are looking positive. We still have got some norovirus. Colleagues have also mentioned COVID. We can't see any signs of it coming at the moment, but we never know. So we may see a COVID spike over the course of the next couple of months. But we're now moving into our lessons learned phase. So quickly working with our systems and our regions to understand the things that went well, the things that we could have done better, and that we're able to capture those. We've already partly done that through the planning guidance, but we will do that further through the UEC improvement plan, which we will be publishing in due course. Thank you, Emily.
Thank you. So just final thoughts then, Richard. I think it's clear we've continued to make progress and we need to continue to improve. On elective care, it's improving, but we need to accelerate the move towards restoring the constitutional standard on RTT and reducing long waits at the same time. Urgent care, as you've heard from Sarah Jane, is under daily pressure, and we need to do more to make sure good practice, including caring for patients with dignity, is supported everywhere in the system at all times. Diagnostics and cancer performance are improving, but building further improvement and productivity in is essential, particularly as part of, again, the return to the RTT constitutional standard. And as I'm sure will be reflected in some of the other papers today, we experience every day that delivering is the bread and butter of the NHS in all of our services. But with increasing demand and acuity, it isn't enough to just deliver. And our work with systems this coming year will therefore focus on not just how we manage the pressures, but on improving the service, continuing to support staff to bring the best of the NHS to the rest of the NHS. Thank you.
So I'm going to, before we bring Julian in, pause and see if colleagues want to ask any questions. If I can start with one, actually. And it's partly I want to build on the earlier tribute, Andrew, to you. Because, again, when I first arrived, you were always hammering on the message of early winter planning. The earlier we plan for winter, the earlier we get at the necessary enablement. And I think that, I'd just like to see with Sarah Jane, I think that did make, again, an additional difference in this last winter. And can I just pick up that point about there's an urgent emergency care, lessons learned, further plan emerging. You said that will come out in due course. Do you know roughly when that's going to come out? Because effectively that is picking up, I think, even earlier winter planning. But for each of the last couple of years, we were tempted to do that ever earlier. But
yeah, we don't have an exact date, but it will be over coming weeks, and it will be arriving with systems in time for people to be able to take a look at the content as they're going through the planning guidance. But it will not be setting any new targets or measures over and above those that are already in the planning guidance. It's about supporting people in the delivery of them.
And then I would just, it's not a question, I would just also like to comment and thank you and Emily and the whole team, and then all of the systems actually. I mean, it is such an intense period of so many different steps that get taken to try and prepare us for the surge of demand that comes through this period. And you referenced one point, I think, where you said, I think just before Christmas, you took bed occupancy in our acutes down to 92%. And that gives us some enables some greater capacity for what I think you've taught me, or Emily's taught me, which is actually we get a real peak pressure coming pretty much immediately after Christmas and into the first week of the new year. And actually we're just getting ourselves ready for that surge. And it strikes me that is always a good preparatory step. But I just want to give my thanks to everybody who's battled so hard through this winter looking after patients and a higher volume of patients who come to us. So let's go, Robert. I'll work around this way. So Robert, then Mark, then Duncan.
Yeah, thanks very much, Emily, for all of that. Just zoning in on community diagnostic centres, which I think are a terrific innovation, and having had a session with the person leading that, I think they're doing a brilliant job. But it's far from national coverage yet. It's not at the scale that we would wish. Really important because it should impact on cancer rates, obviously, and it should have an impact on the elective waiting list. So two questions. One is, can you evidence the fact that they are doing those things, they're having those benefits to make the case for further rollout? And in theory, over time, this should be kind of cross-neutral, because you should be able to reduce the hospital-based diagnostic facilities as you expand the community-based. So I'm just interested in how we can best make the arguments for expanding this capacity.
And Emily and Sarah James, let's batch the questions up. We'll do that technique if possible. So Mark?
Clearly a very, very difficult winter. There's a productivity paper later. The numerator and the denominator are moving all the time. Mm-hmm. What's the actual real demand growth that you're seeing, and what should we be factoring into a forward look? Because at the moment, it's intuitively quite hard to understand the underlying pressure on the system that is coming and is going to come in future years.
Okay. Duncan?
Yeah, probably more. More of a statement than a question, Chair. But I think just the RCN report on corridor care, I think, brought into stark focus not only the experiences of patients who are being cared for in temporary escalation spaces or corridors, but also how difficult it is for staff who want to turn up every single day and do their very best for patients. So I just wanted to recognise that and how important it is our continual work on making sure privacy, dignity, safety is paramount for patients in that situation. And myself and Steve Powis are going to be working with our regions to see what else we can do to help support that. And clearly part of the work with Sarah Jane on the UEC plan will focus on that.
And Mary, you made that point very strongly in this morning's board, actually, about the importance of patient safety, really, really important, but patient dignity is also really important.
And I would echo exactly what Duncan has said and applaud the trusts that have recognised that they need extra nurses in certain areas because they are exceeding the number of patients that they ever anticipated in their A&E. And that should result in better care for anybody that is in a corridor.
Thank you. I'm going to go,
So Jane, I'm interested in the lessons you've learned and where the stresses and strains came in the plan you put together sort of summer last year to deal with winter. Because, of course, the situation's changed, conditions changed, assumptions about the state of the state, the vaccine, the efficacy of the vaccine, all that sort of stuff. So going into this year's planning, are you able to give some sort of things that you're looking and going, actually, this is an issue, that might be an issue, this is how we do better? Thank you.
And then I think there's one more, if we can go to quite a sizable batch, which is Andrew, I think.
Thank you. So a couple of points from me. One is take-up of the flu vaccine this year, and has that made much of a difference? And the other one is around activity. So we see around 2.3 million people through the emergency departments in England every month.
Every month, yeah.
How many of those people could go to other settings? Because I think we've still got a big job to do around directing the public to all the alternatives that Sarah Jane, you've kind of planned and we've still got a lot of behavioural change to enact, because people still think if I'm ill and it's out of hours, I go to A&E, and there are lots of alternatives available. Just give us a sense of the scale of people who you think are pitching up inappropriately.
Okay, so Emily, do you want to pick up a couple of those, and then Sarah Jane, there's some specifics coming at you.
I'll pick up a couple, and Sarah Jane will pick up, I'm sure, the ones about winter. So on CDCs, just on the capacity point, at the moment, we're basically using all the capacity we add. So there isn't a displacement going on from trusts. There is enormous growth in demand, and the CDCs are helping to deal with that. In terms of your point about how do we evaluate whether it's meeting the needs of local populations, etc., there's evaluation work ongoing, and I will bring it back to the board when we have something on that. Given the increase in demand, it's quite hard to separate that out from different effects. One of the innovations that I've seen some CDCs being able to do, particularly after sort of 6 or 9 months of operation, is to change their booking systems, for example, to make it more accessible to the local population, as opposed to often when it starts, it is mandated by the local system, like you have an appointment at X centre. But some CDCs pointed out to me that system doesn't know how people tend to drive to work, for example, or, so I think we collectively, locally and nationally, have work to do to make sure we're making the most now of this more dispersed network of services. But at the moment, we need all the capacity all of the time, effectively. On your point about underlying pressures and demand, we are obviously, as we plan services, and ICSs in their commissioning will be looking at this as well. All of the models have built in expected demographic changes, etc., increases in multiple comorbidities. The couple of things we need to do more on that. The first is we are often at the moment considering them with related assumptions, but in different models. So for cancer, for UEC, for elective, etc. And one of the things we are doing at the moment with Vin's team, support Vin's there, is to use more advanced data science techniques to try and put together all of those different assumptions and the different changes we're seeing in different modalities to make sure we're really predicting that accurately, and we can build off of that. And to consider other effects of local performance, including, the structure of local infrastructure, etc., which is in its infancy, but I think will be helpful as we try and build that strategically, and less in terms of next winter, but more in terms of the longer term planning.
Do you want to come in, Julian?
Just on the demand growth,
yeah.
Look, on average across the NHS, it's about 3% a year, of which this number isn't precisely right, and people debate exactly what it is, but it's like about half is demographic and half is actually treatment and technology.
And that's compounding out into the future.
That's compounding out into the future. So when we plan for the future, the thing you've got to work out is how you deal with that, and that's like then your funding and your productivity challenge.
Sarah Jane, a couple of points.
Yeah, I just got 3 quick areas, and if I could maybe ask Steve to say something on the flu vaccines, because he's my highly knowledgeable colleague. So just a quick run through the lessons learnt. We've got lots of things working across all the individual parts of the pathway really effectively, but there's a lack of consistency. So we've got sort of fragments of services that people have developed, and when they're open, they work really effectively, and we can look after patients really well at home or in alternative settings to taking them to hospital, but they can sometimes close at 7 o'clock or run out of capacity on a weekend, or those kind of things. And therefore, while patients don't always need that hospital care, that those services need to be there in a more consistent way, and that's one of the things the neighbourhood health guidelines that are part of the planning guidance is really trying to drive at, is getting that more consistency into the neighbourhood sort of health offer. I think also within hospitals, colleagues have touched on it here as well, but it's that getting the clinical decision making as quickly as we possibly can in pathways, and really the organisations that sort of geared up to get that clinical decision making as close to the front door in the medical assessment units as possible tend to fare better over the winter period. And then it's that partnership working with health and social care. And I think obviously Julian's answered the sort of overall demand question, But we really encourage systems, and we need to continue to do more of this, to do their own version of the demand and capacity planning in their local context. So what capacity do we need in every part of the system for this to flow? Because when one part breaks down, patients end up somewhere else, which is often not the right place. So that remains really important. And then just on the acuity, it's really difficult, I think, sometimes. Are patients appropriate to be, or are there alternatives to being in an emergency department? It's a really difficult question to answer this, because services are organised very differently across the country, aren't they? And how visible UTC and other services are. But as I think we've talked about before, when we've done the acuity work with organisations, so we look at the presenting symptoms of every patient that comes through the front door, and that's a proper assessment is done by a clinical team member. Around 40% of patients are scoring with an acuity score of 4 or 5, which is more suggestive of minor illness, things that could be done in a UTC, minor injury unit, etc. Now, in lots of organisations, we can stream those patients into those services, so they find their way from the front door. Because of the way some of our organisations are set up, that is less possible. But it suggests that around 40% of those patients, if those services are available elsewhere consistently through the day, do not need all the support of a full Type 1 emergency department.
Okay, can I just slightly come back, because you phrased something very carefully in your response.
I'm glad you noticed.
I didn't.
So availability of clinical decision making.
Sorry?
Availability of clinical decision making.
Yeah.
If I did my words, which would be like layman's, which is sort of more consultants at the front door.
At the
right times.
Yes, and it's not just. It's the appropriate consultant for the group of patients that are coming through. So we've often got our emergency department colleagues and our acute physicians at the front door. But as soon as patients are identified as needing to go to a cardiology ward or a respiratory ward or whatever, those organisations that can get that consultant or that senior clinical decision maker to that patient as quickly as possible, started on their pathway and treatment of care, pulled through to the ward, tend to have a lower length of stay, be more productive and efficient, but also get a better outcome for the patient. And that's the thing that we need to continue to work with organisations and clinical colleagues.
And a bigger payoff overall for the trust involved, right? Because the flow works better, etc., etc. So in your plan for winter coming, 25, 26, how do we ensure that happens more consistently across the piece? So I'm just pushing on this because I think it's a really important point and a really key intervention.
So there are some things that we can do to support, and our GIRFT, Getting It Right First Time, and our ESIS teams, they have got tools that they use to work with organisations to look at consultant deployment, consultant job planning, and so on and so forth. And there are usually improvements that can be made. In some other organisations, some smaller DGH, for example, it can be difficult to have enough people on rotas to make sure people can put all the time necessarily into urgent and emergency care, outpatients, diagnostics, etc. And so we do find ourselves sometimes working with places where that is more challenging to achieve.
Thank you. Did you want to bring Stephen on vaccinations? Sorry, Vin, did you want to comment?
Yeah, I was just going to come in on the point, Chair, thank you, that Andrew asked as well about patients attending emergency departments whose needs aren't best served by an emergency department. So I think we have done quite a lot on this over the course of the last year or two. So firstly, what we say to all patients is that if you're unwell, you should contact your general practitioner first. You can do that via telephone. We've put in place digital telephony now to make it easier and stop the 8 a.m. rush. We have also put in place the availability you can request a digital consultation online over the last year into general practices across the country. Thirdly, there's a thing called the Directory of Services, which is available through the 111 service, which is what 111 call handlers use in order to direct patients to the service that best meets their need. That has had a big technology update, and we've encouraged all integrated care boards to update so they have accurate directories of service. And then, of course, in all our public communications, we encourage people only to use emergency departments and 999 when they are worried they've got a life-threatening illness, and actually to use their general practitioner in the main, or 111 if they're not able to contact their general practitioner, for example, out of hours.
Very good. Thank you very much. Very helpful. Vaccinations, Steve?
Yeah, thanks, Richard. So just to remind colleagues, we ran this year 3 respiratory seasonal vaccine campaigns, so RSV, flu and COVID. We'll just concentrate on flu to the point that was raised. Again, it's probably just worth reminding colleagues, we started the flu campaign a month later than historically. That was deliberate, it was planned, and that is on the basis of clinical advice to kind of maximise protection. And then if you just think about the sort of uptake point that you raised, Andrew, so we did, uptake is broadly the same as last year. There are 4 main cohorts. So in the 65 plus cohort, the uptake, so the proportion of people taking up the offer, is about the same as last year. It's broadly the same in the clinical at-risk group as last year. And it is slightly better than last year in the 2 to 3 year old group and in the school age group. It's not, I mean, it's like 1-2%, but it's not unimportant. And I think all that said, the kind of the clinical advice on this is, and this is what we're starting to think about for the coming winter. So the clinical advice is you get a very important benefit from 2 to 3 year olds and school age children. So that's an area that we are giving some particular thought to in terms of this coming winter. The cohort where we have lower uptake across all vaccine programs is what we call the clinical at-risk group. So it's people who are under 65 and have a condition that puts them more at risk. Many of those people don't see themselves as at risk, and so there's quite heavy complacency in that cohort, but that is an area that we need to continue to try and focus on. And then just for completeness, in case it's helpful, although flu vaccination uptake has broadly stayed the same or got slightly better in a couple of the cohorts, for COVID vaccination, that doesn't hold true, and we've seen a decrease in uptake across pretty much all cohorts, including the older age group, which is not, again, it's important to consider. Compared to last year, there's again quite a lot of complacency around the COVID vaccination now. So.
Thank you. Claire, you wanted to just come in?
Just building on the point about the importance of clinical decision makers. So we talked about having those systems, those trusts where it works well because they've got really good connection between the ED and the specialties. I think the other place where it works well in systems is if they've got really good relationships between primary care doctors and into secondary care specialists, because often then a conversation between the GP and the specialist actually means that the patient can remain at home or could be discharged earlier because actually the communications are there if problems arise. So I think it's important to recognise the importance within the hospital. There is also that piece from the hospital coming out into the community. Thank you.
So should we move on? Can we move on? Julian, to you on financial update.
So, again, I assume people have read the paper, but in summary, Table 1 sets out the position at the end of month 9.
Yeah.
There is an ongoing sort of worsening position as you look at systems for their performance against plan, although the deterioration has actually markedly slowed down as we've gone kind of through month 8 and month 9. And in aggregate, we are sort of £600 million behind plan when you sort of take the whole of NHS spend. Now, I will say I'm absolutely confident we will hit the budget, and in part at least that is because of the action we have taken centrally in anticipation a bit of the sort of further efficiencies and savings we are delivering through NHS England, which will be about £500 million by the time we get to the end of this year, and we are targeting about just over a further £300 million as we look ahead to next year. So, I'm confident we are going to hit. We will live within the total mandate the financial mandate we've been given by government, and although we're behind plan, I will flag that systems have delivered £5.7 billion of cost improvements to the end of month 9 compared to the same point last year that is £900 million more. Last year at the same point that would have about 4.8. Now that is a mixture of like genuine savings, productivity gains, and where they have done more activity, sort of earnings and income benefit. Nonetheless, that is still a pretty sizable improvement. However, they're £400 million behind where they set their original plan. So people are really working hard. But, you know, we knew it was going to be challenging, and they are behind. Our biggest driver of cost is the workforce. Yeah. End of the year compared to the end of month 9, the total workforce cost is 0.6% lower than, the sort of run rate, 0.6% lower than it was at the end of month 9. Now, a lot of that is because, as we flagged before, people are really starting to bring down temporary staffing costs, having seen quite big growth in substantive staffing. Agency, we're anticipating, will be about about £1 billion lower than we ended last year. So if you follow the run rate through, we spent about 3 billion at the end of last year. It'll be about, if we carry on the current run rate, about 2.1 at the end of this year. Over 2 years, that is about 38% lower. We can see bank costs, which have been sort of growing historically, flattened at the beginning of this year, are now about 5% lower year on year. So, with the substantive staffing that has gone in, that's good. People are now seriously taking out the temporary staffing cost. That's good for staff, good for productivity, good for patients. And we can see some of our systems who have been most challenged on holding to the plans. We can see with the interventions that have gone in and with the focus of their leadership teams, you can see their monthly run rate improving. Now, we have still got a lot further to go, and we can also see those systems where they have struggled to really turn the corner, and we are working with them to consider, what further work is needed, what changes in support and approach are needed so that we can actually really turn the corner for some of those who have got the biggest relative deficits. So, it's not at all where we'd want it to be. People are genuinely delivering far more than they've done before. Nonetheless, in some places, we have got more work to do, and so we are pretty focused on achieving that change, particularly as we look at 25-26, where clearly we have issued all the kind of planning guidance, we've issued allocations. It took slightly longer to get all the decisions agreed with the whole of government. In particular, we didn't get the final piece of the kind of financial jigsaw until just before Christmas, so unfortunately we did not manage to get planning guidance out the other side of Christmas. Nonetheless, that is all out there now. We are trying to get all the plans finalised by the end of March. That is really challenging for people to do, but we are really focused on achieving that goal and giving us the best chance of success through the rest of the year. If it's worth it, I might just, Richard, cover the productivity paper, given they all, one flows into the other, unless you want to take any questions.
Can I just pause and see if there are any questions? But as colleagues are thinking about them, we should be mindful that we are going to go on, and Julian's going to talk to us about the productivity, progress and challenges. But I just summarise. So we think we're hitting the numbers for the year. You're delivering significant savings. Do you have an estimate for the quantum of savings that we might have achieved this year when we come to the end of the 24-25 year compared with the previous year?
We'll be like £1 billion plus higher than we were the previous year. It's one of those moments when I forget the precise number. We're about 7 billion. We were around 7.5 at the end of last year, so it'll be closer to kind of
8.5, 9.
Yeah.
That's very good. And then you're clearly giving us a message in the paper that I don't want to be dramatic, but that next year, 25-26, is going to be tougher than all previous years in terms of the level of challenge, or in all the.
I mean, look, as you know, next year is going to be another tough year, and I can cover that a bit when we do the productivity stuff.
Can I jump in? I mean, if you follow the logic of what's being said, which is you delivered even more cost savings, but then there's more money put into the system, and that next year we're pretty much going to be the same, and I know you're going to talk about productivity in a moment, then that tells you that the demand is the problem, right? As in, you're constantly, we've heard it through UEC, we've heard it when Emily was talking about electives. You know, demand is the problem here. And actually, my question then is, how do we sort of balance this? I'm not sure you can answer it completely, but it's a more open question. In really thinking about at what point do you have to start say we have to constrain demand in some way, shape or form?
Well, Mike often talks about tilting demand, which goes actually to the agenda around prevention and early engagement and
otherwise
other
you're
messaging.
constantly running to stand still.
I mean,
what do you use as a segue into productivity?
I use that as the segue into the productivity paper. Look, we said we would just continue to bring regular updates on like where we have got to, given actually the focus on productivity and reform, and we'll get to Wol's question, is absolutely the heart of what we need to be doing, what the NHS needs to be doing now. I'm just going to repeat that we recognise the extra funding we've been given, both for 24-25 and for 25-26, as we have set out elsewhere. I mean, a lot of that is consumed by pay, inflation, higher pension contributions, employer national insurance contributions. And then effectively, we have been dealing with demand, recovering services, improving performance, actually basically through productivity and through making choices about how to prioritise spend as we recover our core services. So, you know, a real focus on productivity, and we have to recognise that in this year 24-25, and indeed as we've set planning guidance for 25-26, we've also had to make some pretty difficult trade-offs and choices. And, you know, there are certain places in investment we would love to be going faster, and indeed, you know, we have to work out how we can still do that. Technology would be one of those. Planning guidance sets out a series of ambitious, and let's face it, really stretching productivity measures for the year ahead. Put simply, in order to maximise spend on frontline care, planning guidance says we need to do about a 4% overall improvement in productivity and efficiency if we're going to balance the money and the ongoing sort of recovery and improvement in performance. And we need to be targeting a reduction in our cost base of about 1% in 25-26. That's going to be hard. We have sent to every acute trust and ICB in the country, we sort of benchmarked, you know, all of the kind of productivity measures where people are on length of stay, throughput per staff, size of corporate, you know, the kind of corporate services, where we think there's opportunity on commercial spend, where we think there's opportunity on their medicine spend, where we think there's an opportunity on like how people are, you know, using continuing healthcare. And that does actually show that there are gains which are feasible within this, you know, at this sort of level. And we are not only looking at how we maximise the investment we have managed to put in on things like technology, for example, the rollout of EPRs across the country, but also how we invest in national scale improvement program to give people the basic skills and to bring people together to learn from each other where they're doing it well. I mean, it's that never ending, take the best, spread it to the rest. And that's one of the reasons for the changes in NHS England we'll do, so we can create the funding to invest in that support to frontline care. But this year, it's like we have made progress. Our latest data says for acute trusts, month 8 to month 8, year to date, productivity has improved by about 2.4%. We are now measuring The same for mental health trust, ambulance trust, community trust. That's something we've not done before in real time. They would also show that they have improved productivity by over 2%, maybe even slightly faster than the acute trusts this year. That data, I have to say, is in the earlier stages of development. So we will, like that is one of those bits of data like we are really
once we clean it.
Yeah, we are really sort of testing, but that shows that we are improving, and therefore, we're setting a really challenging goal. But we do think that particularly if we can get the outliers sort of lifting up, we can target the goals we have set out in planning guidance, particularly if, again, with the growth in substantive staffing, continue to reduce appropriately temporary staffing costs. If we can get organisations to really look at where the growth has been, and indeed how they can use automation and the some of the tech investment that has already gone in to look at the sort of support and infrastructure costs which have grown over recent years, and then again if we can really get the focus on length of stay, some of the basic management disciplines. About the way we are using some of our clinical resources. And actually, we have seen huge progress in the move from overnight to day case rates. They're up over 80%. We can still target 85%. Huge progress in the use of sort of outpatients with procedures. And just to go to Wall's question, so at this point, I do not think it is necessarily a question of us having to have a debate about how you constrain care. I mean, I think we know we've got further to recover from where we were pre-pandemic, and we're making progress. And as we look ahead, we know there are things we can do to get care into the right setting. We'll talk about one of them later when Tom and Amanda present the work we are doing on how do we care most appropriately for people of frail, end-of-life, complex conditions. We know that even on planned care, the work we have done around, in fact, the work the NHS has done about the kind of growth of pre-referral advice and guidance, where we think we've avoided about 1.5 million unnecessary referrals into acute care just by getting better join up of primary and secondary care clinicians. We think we can go further there, and if we can create enough of the right headroom, we know that technology and science will enable actually massive changes in the way that actually it isn't just we do the care, it's actually we do the admin. Because the thing that will really create the paradigm shift in the kind of shorter term is the more we can automate a lot of the kind of basic administrative tasks, because that's the thing which doesn't just target little niches of care, it's the thing which applies right across the board.
So I know, Mary, you want to ask a question, make a point, and then I've got Mike and Mark. Yeah.
It's probably more a reflection than a question. But, I mean, Amanda referred to this fantastic new treatment for people with sickle cell. And that's very expensive, and it's great. But further down the line, the total treatment and care pathway for that patient that receives it, probably over a lifetime, not only will improve the quality of their lives, it'll probably be cheaper than recurrent readmissions. So we're starting to invest at one point, but not yet seeing the efficiency of outcome.
There's an early bulge in the cost for a long-run benefit.
Yes, absolutely.
And a better benefit.
And I think we really need to make that clear to society, the success of some of those innovations that we're adopting now. Yeah. And I was thinking historically, we used to have fever hospitals, and then along came antibiotics. So just as a point.
Mike, you were going to
Yeah, I mean, the theme, or one of the things that's coming out from the conversations we're having is how demand, even in the last year, has increased substantially, but also if you project forward for 10 years, 3% a year is almost 40% more demand than currently exists. And you've also reflected on the fact that you can benchmark, you can see opportunity to benchmark. If you can get the lowest performers up to average, you can see your way to hit the numbers, but that only goes so far. So maybe just like to reflect on our investment in technology and whether or not you feel, or whether collectively we feel that is enough currently to drive the improvements that we will need years 3, 4, 5 as we look forward.
So can you manage, if we go down the line and get the series of comments and questions? You've got Mary and you've got Mike. So, okay, Duncan, then Mark, and then Jane, I think,
Yeah, it was just to reflect, Steve and I are doing a piece of work actually about how do we make sure our clinicians are really engaged in the productivity challenge, be that in terms of saving money, but also about how do you better use your own time, or how do we not waste patients' time as well. So we're going to be doing a lot of work around kind of minimising waste, maximising care, and our approach to that. And actually that bit about how do we share some great work that's already going on in organisations, but how do we lift that, how do we share that with our clinicians and our clinical community.
Very good, thank you.
So one, Mike's at least partially stolen my thunder, which is at what stage do we actually have to invest to cover a 40% growth in demand? The second question is just a clarity point. It's very easy to talk about 2.4% efficiency this year, 4% next year, plus 1% cost saving. Could you turn that into pound notes? That if this year I think is the best year we've had for a very, very long time. If we perform next year in line with this year, how many pound notes are we short of the plan for next year?
Can I just say we've had fever hospitals and now pound notes? Is that what it is? I think you're back in an earlier era. But anyway, I agree. That's a question for you, Julian. Jane?
Thank you. Earlier this week, the head of the National Audit Office made quite an interesting speech about innovation and risk-taking in public services more generally. And obviously reference has been made to, we will need to innovate and continue to innovate a lot more, I think, to hit these productivity targets. So I just wondered, whether we can kind of perhaps do a bit more to drive that culture. I mean, we've obviously got to make sure he says, he commits to an accountability and scrutiny framework that encourages well-managed risk-taking, and that's obviously important. But I wonder whether we can do a bit more to drive that culture through the NHS, given that sort of umbrella signal, just to, because I suspect that, using the phrase that you mentioned earlier, Julian, about, making sure the rest are as good as the best, I'm sure innovation features very highly amongst those who are doing things really well and sort of hitting these exacting targets.
And then lastly, Julie, if you could there was one more question coming at you, which is Andrew, I think, or a comment.
Yeah, thank you. So just to amplify one point, on the recovery support programme that we run, or Emily runs, we are seeing organisations start to turn around. Yeah. So if you take North and Mid-Essex, they had a challenge of taking out 600 people at the beginning of this year. They're on target to do so. Kings, who've really struggled historically, financially, they're starting to turn the corner. You've got the Hampshire system that had about 600 people over budget, and in essence they're starting to get that back into balance. So we are seeing people taking basic governance kind of issues around, you can only spend money if you've got it, and you can't spend it if you haven't. Yeah. And that discipline is very simple, but it needs to be there if we're to deliver the numbers that we need to deliver for next year. And I think that's cheering, actually. And the programme that Emily runs is starting to really bear some really positive fruit. It's really good stuff.
So, Julian, there were some comments. And but there are a couple of questions. You want to have a go?
I mean, on the question, Mike's question, it's like we will have to accelerate. I mean, the simplest way of doing it is we will have to accelerate spend soon. We are doing as much as we can within the resource that we have, and where you are having to trade, I mean, just to put it really simply, how do you keep, enabling patients to be cared for today whilst trying to hold on to the right investment for the future? It has to be a serious topic where we really do agree what we're doing as we do the next spending round, which will conclude in June, because to deliver the sort of level of productivity the government will definitely be asking for, and that we said was possible to do 12 months ago or so, we will need to be increasing the amount we're investing nationally and giving a platform for people to do what they also need to do locally. So, I mean, soon would be, we will need to see further step up in 26, 27. We've increased our aggregate investment's about 30% higher than it was 3 or 4 years ago, but we'll need to see further steps, at least of that sort of size, I think, over the next couple of years. In answer to Mark, your question, well, if we've done about 2.5, we're on track to do about 2.5 this year, so to get to 4, that's like 1.5, and if you want to turn that into pounds billion, well, that's going to be somewhere in the order of about £2 billion of either cost or performance risk, and that's what we've got to face into now.
So I would say, because I mentioned earlier, I was at the Black Country ICB last week, and then in Sussex on Monday, and they see the challenge. I think they recognise the challenge. They're clearly up for the challenge, but it is a sort of a 1% cost reduction, 4% productivity challenge across the systems, and some of them, of course, have got non-recurrent and other challenges as they enter next year. I'll just share one. It's not for a comment about June. Just one sort of learning I've had coming into the NHS from actually the private sector, and actually I know what to say because I use this rather glib phrase, but for me it captures very much what the NHS does, which is that quote from Gladiator 1, which I've used before, which is, whoever or whatever comes through those gates, we deal with. And the difference with the private sector is I can choose to close a retail outlet because it costs me too much to reinvest in it, or I don't get the footfall's not what I want, or I can price the customer cohorts. I can choose what I offer. And so the independent sector, the very really good independent sector, the health sector here, they choose their cohorts and they choose their interventions. The NHS has to do something very different. Whatever comes through those gates, we deal with. And so actually some of the levers you have in the private sector of choosing your segments, it's much, much, much more difficult. Choosing where you compete. It's much more difficult for the NHS to think in those ways. And then actually all the stuff around managing within the current resource, everyone will have huge ambition, Mark, supporting your comment to invest in technology. The question is, okay, how can we get and free up sufficient resource to invest in the technology? One, to make our current technology more efficient and more cost effective, but two, actually to invest in new technologies that enable us to be more productive and better at what we do. But the private sector, I think they have different levers they can pull than we do in terms of what they choose to deal with, because that's how they compete. And we have a national obligation to deal with whatever comes through those gates, and it's really different. Julian, thank you very much. It's a very good paper, actually, and also I do think the rhetoric around productivity, it misses that point about the private sector difference with, I think, the National Health Challenge, but also actually what we measure, and it's good that you're now bringing in measuring mental health and community and ambulance, because the measures that get talked about are predominantly in acute, and we also know that it doesn't, for instance, capture virtual wards, it doesn't capture much of primary care, it doesn't capture the growth in diagnostics as fully as it might. So we're not measuring it quite accurately, appropriately enough, but that's not an excuse, it's not being defensive. We're getting better and better at the measurement. But actually, I still think these levels and these actions you're taking, which are getting us 2.5% of productivity improvement in this year, and then we're going for 4% next year. I think it's a very tough but necessary challenge. So thank you very much. Let's go on. So it's Children and Young People update. Duncan, I think you're leading. We're delighted to have Simon Kenny with us, so good to see you again. Do you want to introduce or do we go straight to Simon? Or?
I'll frame it and then hand over to Simon. But thank you for the opportunity to talk about children and young people today. You talked at the beginning about the work of our subcommittees, and the Quality Subcommittee had recently had a conversation about children and young people and the work we do, and I'm sure Robert will want to come in on that at some point. We also talked at the beginning about how ambitious we are. We are ambitious for the care that we provide to children and young people. The government has set an ambition. One of its ambitions is around raising the healthiest generation of children ever. But we are against a backdrop of some significant challenges for children and young people, and the health of children and young people. So we've seen an increase in the complexity of health needs for our children. There's been a doubling of those number of children with 8 or more chronic conditions over a period of about 6 years. We see an increase in obesity levels, mental health needs. Darcy in his report highlighted the pressures that were on acute and community services, and making sure also through our elective recovery plan, for example, about making sure we've got equitable recovery for children and young people, and also our access and waiting times in community services. So I think it's really important for us to remember that with probably 1 or 2 exceptions, all of our services and everything that we talk about in this board, whether it be about cancer, diagnostics, primary care, children and young people are seen through those services. So really important that we continue our focus on that, and also mindful that our ICBs and our trusts have to work closely with services such as education, because obviously the importance of children's health for educational attainment, employability, and then obviously the wider implications for society and moving into adulthood and employment. We do have a Children and Young People's Transformation Programme, which is doing some fantastic work, and I'm sure Simon will talk about that in a moment, which is focused on some particular areas to do with improving care for children and young people. But one of the jobs that we have within the work that we do is to try and bring together across NHS England all of our teams that are working across areas to make sure that we are focusing clearly on the needs of children and young people, but also importantly giving voice to those children and young people. It was great to join an event in November around the 10-year plan, which was focused very much on children and young people, and the team have been working with the 10-year plan team to make sure that the voices of children and young people and the needs of children and young people are reflected through that. But it was started by 6 of our youth board members who, I have to say, have no filter and just say it how it is, and it's really refreshing to hear actually their views around this. So one of my challenges to the board today will be around what more do we need to do to make sure that we are hearing the voice of children and young people in our interactions and the work that we do, but also then how are we making sure that all of our discussions around any of our work thinks about the needs of our children and young people, and also then the work that we're doing to influence the 10-year plan. So I'm going to stop talking there. I'm going to hand over to Simon, who's our National Clinical Director for Children and Young People.
Thanks, Duncan. And for those who don't know me, as well as being National Clinical Director, I'm a practicing paediatric surgeon at Alder Hey Children's Hospital, using AI for the first time this week in my clinics. It's a game changer, I can say it. And what I would say is everything you've heard this afternoon about increasing productivity, it's playing through into the front line.
In what way are you using
using it in clinics to basically summarise what discussions take place in clinic.
Is that, say, voice to text? Is that the diagnosis or the
It just it listens to the consultation, it summarises.
Brilliant, yeah. Voice to text, ambient documentation.
I am the world's slowest typist.
So you haven't seen me. It's,
we have a competition.
Anyway.
Just going back there, we've talked about demand, and really what we're looking at here is super forward demand about what's happening with children and young people. And so just to put into context with what Duncan said about, for instance, children living with obesity and excess weight, what we start to see is the signals in that start to play through in every single organ system, not necessarily during childhood, but certainly in early 20s, 30s, where we see, for instance, people need joint replacements, etc., etc. And so if we don't get children right, then the burden on the health service will get longer and longer, because the number of people who spend lots of their life living with illness rather than living their lives is going to suffer. Not only that, is that every single parent, and we all want, it's a natural human thing to want the best for our children, and our children to be emotionally resilient, mentally resilient, and have a healthy life. And again, if we don't get that right, we won't have the workforce of the future. It's a competitive world out there. And again, what Duncan says is that we also have strong links across government, because the implications of what we do with the NHS will have implications for the future health and wealth of our nation. So just running through our programme priorities, it's a slightly mixed bag. So there's 5 areas we're going to focus on in the report. The first one is reducing elective waiting times, and the number of children relative to adults waiting for elective treatment is actually less. So it could be easy to oversee, to lose sight of that. And we do see that children are waiting longer for elective treatment than adults. And we've recognised that over the last 2 years. And I'm also the GIRF responsible lead for children. So we've worked within the GIRF programme and have set up a delegated governance to respond to that. And in particular, we're going to use all the innovations that are coming through in the elective plan to sort of drive through that and make sure children get part of the action. So one example is challenging surgical hubs to take on children's surgical activity. At the moment, 1% of children are going through surgical hubs. If you did it on a per capita basis, it would be 5%. And so the challenge is, how can we put children through and get them through so they can get treated faster? Similarly, with community diagnostic centres, the emphasis has been on adult diagnostics. So we're working with the CDC team on how we can accelerate diagnosis in asthma and epilepsy and children with musculoskeletal conditions. And this also saves families money, because every time we bring people into centres for treatment, it's a huge cost for parents and families. We've got the working with advice and guidance to make sure that we can reduce unnecessary referrals into hospital, and the electronic referral system, we're working with them to put prioritisation tools that are built into it, so that we can see the priority of the referral as children are referred in. Moving on to community and mental health services waiting times, this is an area which I think we are concerned about. We know we haven't done enough about, and there's a number of reasons for this, and which I could take up the rest of the afternoon, to be honest. But it's certainly an area we really need to focus on in the 10-year plan. Looking at the DARSI 3 shifts, the areas that we see huge benefit in that is moving children out of hospital into community, using the integrated neighbourhood teams model. And the advantage with children is that that's been being done for the last decade. And so we've got an evidence base that it's not just theory, it's actual practice. And we know that if we do that, we can reduce A&E admissions by 22%, we can reduce hospital outpatient appointments by 42%, and elective admissions by 17%. And that's by embedding paediatricians into primary care and working in partnership. In terms of looking at sickness to prevention, we've got a number of specialised clinics for children with the most extreme weight, but we've built in that a data set which allows us to capture the experience of those children and work out what worked. And the National Audit Office has long criticised our interventions in terms of obesity for the lack of evidence base. And the sort of issues we're sort of working with that is, what's the role of GLP-1 agonists? What's the role, which models work best in terms of providing support to those children? And also we've got a novel apps that we're introducing which can play a role. And the early data shows that the earlier we intervene, the more impact we can have. And so early recognition is really important. One sort of, it's quite bleak, a lot of this summary, I know, but one area where we think we can celebrate is the early warning system in hospitals. So in the last year, we've introduced the National Paediatric Early Warning System, and it's the largest early warning system in the world. So we're the biggest nation that's done this and standardised the ability to detect a deteriorating patient. And we're launching that into emergency departments in the coming months, and then turning our attention to how do we detect the 3,000 children that deteriorate in the community annually. So we can get out there, and that's going to involve use of machine learning and artificial intelligence as well. And then finally, I'd just like to emphasise the key role of the shift from analogue to digital in providing improved healthcare and outcomes for our children. And in particular, the most exciting thing at the moment is the NHS proxy access, which is where in the NHS app, parents can access their child. And that is the fundamental building block for a digital child health record. And I'm confident in the next few years we'll start to have the first digital citizens that their entire healthcare record will be kept within the NHS app. So on that, I will probably stop.
And we'll open for questions. Well, thank you. I mean, I can see a flood of hands going up. So Mark, I'll go Mark, then Ben, then I'll come this side. If that's good.
Thank you very much. So firstly, I welcome this paper. Secondly, just picking up something that Mary said earlier as well, the return on investment in young children and young people who have their whole lives ahead of them is far greater than the return on investment on me as I approach my second childhood. So I can be unfiltered as well. So we were asked to approve the strategic priorities. There's one area that I think is absent. You talked about paediatricians, but actually it's teeth. Dentistry, that is one of the major things that puts children in hospital. There are relatively simple interventions that can help that, prevent that, and dental health has lifelong impacts actually. Yeah. And so it seems to me that it's really important that that is included as well. And I think that you rightly identify all the challenges there are. I think personally we speak far too little at the board about children and young people. And I think the challenge now is to turn this into a plan.
Okay, so Simon and Duncan, we're going to go round and batch, otherwise it becomes a game of ping pong. So hard luck. You have to sort of keep a note of the questions or the points, and then if I can get you to respond with Duncan at the end, if that's okay, as we go around and pick up the questions. So, Vin?
Yeah, it's a comment rather than a question, actually, Chair. Thank you. So, I've been a paediatrician for, I think, more than 30 years now. I was medical director at Birmingham Children's and then at Great Ormond Street. And so I've been trying to improve things in this area for that period of time. I have to say, and I just want to pay tribute to Simon and Sarah Jane and Duncan's leadership in this area. They, as a team, have made more progress on some of these issues in the last 5 years than in any of the previous 20. So I think it's been an outstanding team that's worked on this. And I do really want to support Simon's point that the report itself really illustrates and brings out quite starkly the range of challenges across both physical, dental and mental health for children and young people. And this is an area we have to tackle as part of the 10-year health plan, because as Mark says, if we don't tackle that, we are stacking up a load of issues that then the future board will be talking about in relation to the conversation we've just had with Julian.
Thank you. So sometimes their comments one just can reflect that, but listen out for questions. So we'll come up with Robert, I think. Then.
Yeah, well, I just this came to the Quality Committee, as Duncan mentioned, and I just wanted the whole board to be cited on this, because I think Simon used the word bleak. I mean, it's really challenging. Yeah. Some great stuff going on, but it's very challenging. And I mean, the fact that elective waits are longer in kids than adults just has to be seen as inappropriate. And it's important for the sake of our kids, but as you pointed out, it's important for the rest of life. And if we don't solve these problems and address them properly, then we're just making problems for ourselves downstream. There's also a big inequality agenda here, and some of the statistics there, again, are very concerning. And I think the point, I'm not sure who made it, but kids don't have the loudest voice, and that's why it's really important, I think, that we hear it. I think the youth board is fantastic, and that is a voice, and they certainly make their voice heard. But fundamentally, I mean, when the paper came to the Quality Committee, there was a very good set of actions at the end. They're not here, but there are clearly actions and solutions that you have in mind. It's a matter of whether we can invest appropriately in them. So I think the reason I think this is timely and important is because we are thinking 10 years ahead with a 10-year plan, and I just really think we have to give this enormous emphasis.
Thank you.
Thank you. So, leap on the bandwagon. I'm delighted to see the emphasis on children and young people, because we just don't talk about children and young people enough. I chaired one of the work streams for the 10-year plan, and Simon and the team came and spoke to our work stream, and it was incredibly impactful. And we took three things, I think, from it. One, this was that, yes, children are involved in all bits of our service, including frailty, which I think we sometimes forget. Some of our children can be some of our most complex children. And just by assuming that they've got the same condition, unless you specifically design the services to work for children and young people, we will miss it and we'll get it wrong. The second thing was the importance of transition from children's services into adult services, and you can't start planning early enough for that. And then thirdly, it was really just this, if we get this wrong, this will impact upon a whole generation.
Thank you. Mike, you, Wal?
Thank you for the paper, thank you for the comments. So when I was chairing Guy's Thomas's Foundation, we did a huge amount of work on things like childhood obesity, children's mental health. And the bit which I'm sort of wanting more from is just to understand more about how you're working with people out of our system that have already done a lot of this work and got sort of areas of expertise and understanding of how some of the stuff works. Because I didn't get enough of it from what you actually wrote or what you said. Because I mean, I could almost, in my head I know the phrases we're using, which is, it's not about willpower, it's about environment when it comes to obesity. It's about the housing situation, it's about the parental situation, it's about the cultural situation, which is far more determined than anything we say to children. And that crossover with the inequalities as well, so the core 5 plus 20 or 20 plus 5, whichever way around it is, I can't remember. But that also was in there. It's a very complex soup, and I'm just sort of puzzled why there wasn't more about what other people are doing in your paper. Maybe you'll tell me it's just you haven't said it. Thank you.
You okay picking these up? And then I think Mary, I think you wanted to...
Thank you. Just two things. I think under 10C, where you're developing a metric for measuring waiting times for community mental health services, absolutely fantastic. We've never done it, and I just want to commend you on that. And my other question is this paper covering the 0 to 5s? Because we do know that children are going to primary school without sufficient language skills. I mean, not a high proportion, but a concerning proportion, and some even not out of nappies. There is some evidence that health visiting numbers have been significantly cut disproportionately across the country, and I just wonder whether you could comment on that.
So, Simon, Duncan, I don't know how you want to pick those up, but you'll have to sort of signal across to each other, I think.
Yeah, we'll seamlessly
say. We'll have a go at some of those comments or questions.
I'll answer the easy questions. And
good boy, good move. Yeah.
So, you could and actually it addresses several of the comments actually, which is this started off as a much longer paper, and it necessarily has to be trimmed down. Because essentially what we're covering is almost every activity that the NHS does. So it could be a separate board in itself doing the whole thing, and I'm very willing for us to do that. But teeth are definitely in there, and there's a bit about elective recovery, but every child that has its teeth removed is a failure of public health, and it's how we work with public health colleagues in terms of reducing that. There's things like mini mouth care matters, assisted toothbrushing in schools. There are initiatives, and in fact, the oral health of the nation of children is improving. That there is a massive deprivation signal coming out of there. With regards to external review, we've got within the governance, we have external stakeholder bodies that provide us with professional assistance and support. We work with things like the Academy of Medical Sciences and the Royal Foundation to generate best evidence to guide us in where we go in terms of future strategies. And the metrics for community waiting times, absolutely agree. I think we could probably go further. It would be great to have something like secondary user statistics in the community, a sort of real live recording. At the moment, this is still quite a manual process, which we'll be going through. And I'll hand over to Duncan for health visitors.
Great. Just before I do that, because somebody mentioned electives. So there's something actually, it's in the paper, but the importance of visibility of this and the visibility of data, and there's obviously a commitment within the elective recovery plan about the visibility of children and young people's weights, but also about the importance of ICBs focused on that as well. So I think that's a really critical thing that we need to make sure is there. And then also just reflecting on the point about this isn't a paper that's covering every element of because we'd be here all afternoon, but there is something then about perhaps how do we do that when we do see a paper about dental, or how we see a paper about as we go forward, just thinking about what goes in our papers in future things and about the needs of children, like we try and cover the needs of inequalities, etc. On health visiting, absolutely, and there's clearly a government commitment around health visiting. This is obviously local authority commissioned, but you may probably know that the professional leadership of public health nursing has moved to the chief nursing officer about a year ago, and so I'm working very closely with the office of the chief public health nurse on what we do around health visiting, particularly, and as Simon mentioned, the Royal Foundation are doing some really interesting work on supporting health visiting as well, and we've been talking to them. So I think there's a lot more to do in this space, and partly that is about the visibility of the work that they do. It's evidence-based, and certainly that's something that I'll be focusing on.
One question, I think it's a Julian question as much as anything. And it's something Mark said there, that this population has the highest net present cost of their entire lifetime and the lowest voice versus, and Mark, you said an older cohort which has
your second childhood,
in their second childhood, probably the largest voice in our society at the moment because of demographics and voting, and yet the least benefit. How do we as a board face into that funding mismatch? And because this is really a marginal allocation of resources question, and in a world where there isn't enough funding, it feels like, how do we make this much more explicit in our recommendations and the way we make decisions?
So I think it's a very good. I mean, I do think, and then I might get Amanda to comment, but I think it is that terrible word of prioritisation, isn't it? It's what do we choose to do? Guided by government, in conversation with government, what do we choose to prioritise? Because we can't do everything. So what do we choose to do? And I absolutely hear you on the, it says perhaps the smallest voice, but the best return. Investment. So it is that debate on prioritisation. The other one, which we didn't really pick up in that conversation, was asked, I think, but actually it's partnering. And so if there's one cohort, I mean, there are many cohorts of the population, but there's one cohort, I think, where actually that partnering is so really important, whether it's, I know you do it, whether it's with key workers in schools, going into schools, but it's also in policy. That actually, when we think about what's happening, how many centres have we now got for severely obese children? Is it 30? 37 clinics we've opened for severely obese young children. So there's a lot of policy stuff actually in here where we really need to partner with government, because there's a cohort where, what's that stat? 20% of health conditions sort of derive from health, and 80% of health conditions derive from external factors. So I'm probably naive, but it strikes me as a cohort of the population where absolutely one should be encouraging those partners who are enactors of policy. It would be for this cohort, whether it's ultra-processed foods, whether it's, I don't know, Simon would have a better view, social media on them, the surging levels of demand in mental health, the private market in diagnosis, these things actually are the things that we can do that can actually alleviate some of these pressures and look after these young people better and quicker, I think would be really important. But you can react to that or Oh, Simon, you want to come in, or ignore me? But Simon, do you want to come in then, Amanda?
I mean, just to say, obviously the bit on mental health, you don't put much in about the remarkable increase in demand in a remarkably short period, which if it continues, which is, there's every sign it might, there's no way we'll ever catch up our tail, ever. What should we be doing about that? There's nothing in that.
Yeah, so I think it's a really long question. It's a difficult question, and there's not the evidence. So we need to make a diagnosis as to why it's changing. Yep. It's taking place, and we have to make that diagnosis in order and start to establish an evidence base about what works, and start to think about how we can. And I think a lot of it will probably go back to the early years and how we look after our children in the first 5 years of life. Yeah. And I just reiterate earlier intervention. Yeah. Engendering a generation of children that have got mental resilience and emotional resilience, and that's not something NHS England can prescribe. We can help. But I think that's where a lot of the effort will need to go.
And you helped me with that speech I had to make, I don't know, 3 or 4 months ago, and actually that the deprivation and the connectivity into deprivation and the inequalities here, and the number of children, I forget the stat now, but it's an appalling stat actually, the number of children living in poverty and absolute poverty. You know, it's a real indictment of the way our society actually operates. I think we need to find ways to intervene, I think. Are we okay to... Oh, Amanda, sorry.
Yeah.
Yes, please do.
Do you mind? So just because you've asked some really great questions that I think are probably worth me just giving a bit of a perspective on. But firstly, can I just say, again, thank you to Simon and the team, who I think have done, and you just have to continue to do just the most brilliant job, and for bringing such covering so much ground in such a very well-crafted and focused paper. So I know it could have been many times longer. Clearly, I think this question about what is the approach, prioritisation, etc., just to kind of take that one head on. So when we were talking earlier about planning guidance, this year we have asked the NHS to focus on fewer priorities, and we have collapsed ring fences because we have said to give our local leaders maximum opportunity to work out locally what the priorities are and to deliver the things that matter most in the ways that make best sense. We have to untie their hands. So we have to see that through. And what that actually means, I think, is three things for us. One, and I think Duncan absolutely bang on, we have got to embed explicitly children and young people and inequalities in our core business. So we should not be able to talk about elective, UEC, primary care access without talking about those things. And obviously in our big data packs, we do cut the data by inequalities, and we've made a commitment to do that specifically on elective care for children and young people. We just need to keep going, I would say, on that. Second thing is, we do then need to be clear how we need to adapt the approach that's happening in adult services so that it also works for children, because one size does not fit all here. Yeah. And I'm thinking of things like virtual wards for kids, the MDTs for children and young people. You know, there's a lot of similarities, but they will need to work differently. And so I think there's an and, which is the bit that says, right, if we're doing a set of things which are set out very clearly for tackling these big things, what's the specific guidance or the shape of that needs to be in place so that it's going to deliver for children and young people? And then I think thirdly, exactly as this paper is, we need to be sort of really crystal clear. It's your point about diagnosis, Simon, where the and above that is there is a specific thing for children and young people that isn't covered by those other things, where we would actually say this one needs attention. And whilst local areas might have a slightly different priority set, you know, we would be surprised if this wasn't included in it, given what we know about what's going across the country. So, for example, the specialist obesity service would be a good example of that, where it is different to something that we're doing for adult services, completely different and a clear priority. I think two more things, if I might. So, data is key. And I actually think that's, again, it comes through the paper, but the more that we can do to make sure that we are capturing the right data quality and publishing it thinking about community services as well as some of the other things we've talked about. I think that is one of the things that we as NHS England can do to help. And then my other point, which I think you made, Richard, is just to keep coming back to how much of this requires partnership. So, I mean, speaking personally, and I think others might be thinking it, I think there was huge merit in some of the Sure Start work that was done many years ago, but of course that was a partnership approach, and some of that I think it has huge potential for the future. That's not our decision to make, but it's something that I think, were that to happen, we would be hugely enthusiastic about.
It's interesting that one of the new and newly announced non-execs on the Department of Health was the first director of Sure Start. It's quite helpful.
Right. Well, perhaps we're not misaligned then on thinking about the importance of that kind of initiative. So I think there are some huge opportunities in future in the partnership space, but I think we also just have to be, we just have to recognise how much pressure other partners are under. So partners in education, partners in local government, voluntary sector. We are not alone in needing to think about how we best respond to some of the growing demands on our services, but I think partnership's going to be key. And finally, Richard, I was just thinking, in light of this conversation and the reflection, which I think is right, that this board probably has not spent as much time as colleagues would like on issues related to children and young people, perhaps we could agree to come back to this agenda more frequently.
Pick up the rhythm.
Can I just, given this is my last board, and I wouldn't be part of that discussion, just add one rider to that, which is, I think, Mark, you started touching on this, which is, and Mary, the investment you make for the return down the road is the big challenge here. And how that actually plays in when you're talking about the financial pressures, which Julian has so clearly outlined for us. I think that is part of the conundrum here. You have current day spending going on, and all the pressures that come from that. But actually, when you think, I need to put that extra pound into putting more towards children, young people, or towards the elderly offer, what's the balance here? What's the immediate return? Because if I don't do it, I'm just giving up opportunities down the road. So I think finding a way of describing that, discussing that in your next conversation, he says very happily.
At the next board discussion.
The next board discussion.
Load up the agenda.
Would be great. Thank you.
Okay. Simon, thank you very much. Really, very good. Duncan, thank you. So shall we move on to genomics?
I don't want to give him the last word.
Oh yes. Would you like the last word on that conversation? Final word. The last word at this board. Anyway.
Thanks for hearing. And it's always difficult as an adult representing children and young people. And I'd also really I'd have liked to have had some of the youth board members sitting against me. Right. There's at least one potential Prime Minister in the group. But I will relay the conversation. I'm meeting them just after this meeting. So
excellent.
Should we do that for next time?
Yeah, if you like. Yep. Well, yes, but it's in Leeds, so it's probably.
For the next time we have this conversation.
Yeah, then that. So I think
definitely that wouldn't be the next board meeting.
No, next time they come up on the agenda, then we should bring that into that discussion. Yeah, very good.
I was just going to say, in the same vein, if there's an opportunity when we next come back to this to kind of hear about some of the other initiatives that in the wider kind of society that might be going on to support this, whether it's around, early years support or reducing the obesogenic environment, some of that.
Or school workers.
I think it would be really, really interesting to see if we could have a kind of conversation in the round around that.
Very good. Thank you. Okay, so we are going to move on to NHS Genomic Medicine Service. Sue, it's over to you.
Thank you very much, Richard, for asking me to speak this afternoon about our world-leading NHS Genomic Medicine Service, or GMS for short. And we are really world-leading. We're 5 years ahead of any other country across the world. And I really want to thank Richard, Amanda, the board and the exec team for all this support they've given me in driving forward this agenda, as well as the staff of the NHS GMS for their tremendous hard work since we launched the service back in 2018. In the paper, we set out the commissioned infrastructure of the NHS, and essentially this has created 7 clinical innovation hubs for genomics, and that's important as I come back to some of the things I'm going to highlight in the next couple of minutes. So Richard mentioned earlier that we've delivered over 810,000 genomic tests last year. Now that represents world-leading prenatal testing, world-leading rapid whole genome sequencing services for acutely unwell babies and children, and it also represents an expansion in the more comprehensive genomic testing we do in cancer, and including in paediatric cancer. And that's enabling precision treatments for first-line chemotherapy rather than later down the line. And included in that number of 40,000 pharmacogenomic tests that are preventing sometimes fatal adverse drug reactions to some chemotherapy agents. Last year, we reached the significant milestone of 100,000 whole genome sequencing equivalents in our whole genome sequencing service for the NHS, and that again is world leading. This is a partnership with Genomics England that we launched in 2020, and it includes NHS patients consenting for their data to enter into the National Genomic Research Library that supports diagnostic discovery and ongoing research. We're continuing to really drive operational performance improvements as we deliver clinically meaningful turnaround times for patients. In the paper, we set out that we've made 350 changes to the National Genomic Test Directory since 2018, and I want to highlight a couple of those to show the breadth of the applications and the things that we introduced in 2024. So that included BRCA1 and BRCA2 testing in breast cancer, following the testing that we introduced for prostate cancer in 2023 for access to new cancer drugs called PARP inhibitors. We introduced testing for the APOL1 gene for kidney donors of Black African and Black Caribbean heritage, helping to identify if potential donors carry genes that they may mean they have a risk of kidney disease after donation. We introduced testing for RNU42 gene, newly found at the beginning of 2024 and shown to be associated with developmental disorders. And it was introduced following research on NHS consented data entering into the research library at Genomics England. And that was introduced within 6 months of the research discovery. We have also introduced cancer clinical trial targets as part of routine genomic testing to provide greater treatment options for cancer patients, and as part of the NHS Cancer Vaccines Launchpad, that's part of it is done within the NHS Genomic Laboratory Hubs. We're repatriating sequencing to the laboratory at the Royal Marsden. That means that the sequencing will be done much earlier, and then the individualised cancer vaccine can be made by the company. We've been piloting the use of non-circulating tumour DNA or liquid biopsies for non-small cell lung cancer. It's shown a considerable reduction in the testing pathway compared to conventional testing, tissue-based testing, and we're now rolling that out to other cancer types. And we're supporting Genomics England in the delivery of the Generation study, which will be sequencing 100,000 newborn babies to look for defined set of rare disease much earlier on, given the high rate of mortality and morbidity in the under fives with some of these diseases. And you'll see in the paper we've also driven pathway transformation projects like in sudden cardiac death, where through identifying 108 index cases, we've got nearly 500 family members identified that previously didn't know their risk, and they've entered into inherited cardiac clinics within the NHS. So you'll see again in the paper that we're working very close with Vin and Ming in the Transformation Directorate on the transformation of genomics, data and digital and the infrastructure that needs to support our world-leading infrastructure. And that includes the alignment with the federated data platform, but also the introduction, and we're scoping this at the moment, of a unified genomic record that will enable genomic data to be brought together with clinical data. Through the infrastructure we've created as clinical innovation hubs, we were recognised by the Innovation Ecosystem Review and also by the Accelerated Access Collaborative as an exemplar for adopting innovation into the NHS. And we introduced and established 8 NHS genomic networks of excellence that have been working with industry partners, with research funding bodies, to leverage their resources in areas of unmet need to drive the model of adoption for commissioning in the NHS. One of those is in severe presentation of infectious disease that last year gained another 34 million from the government, looking at sequencing respiratory pathogens from patients who are in intensive care units. A pilot trialled at St Thomas's, Guy's and St Thomas's, but St Thomas's actually, that's really shown you can reduce intensive care bed days, but also use the signal, the respiratory pathogen signal, as an early warning system for biosecurity purposes. So this is a really important development, and that development under that network is also looking at more comprehensive genomic testing on pathogens and on the actual individual in sepsis and also in other clinical presentations. We continue to share our good practice with other countries, and just in 10 days we'll be co-convening with WHO a global network on education and training and looking to share resources, share best practice. We're now at an inflection point for genomics in the NHS, where the demand and the application is showing that we need to increase significantly over and above where we are at around 800,000 to several million. And so there is much more than we need to do than where we've been to date. So with the right investment and prioritisation, genomics has an important role to play in those 3 shifts articulated in the 10-year plan, in the life sciences sector plan, and also driving transformation in healthcare, such that by 2035, 50% of all healthcare episodes would include some form of genomic testing across the life course, from prenatal right through to end-of-life care. In the paper, we've outlined some of the considerations for the future, and these are some of the priority enablers that need to be supported through the spending review that will drive the step change that's required. And some of the challenges we still face are raising awareness across the NHS, ensuring that there's equity of access not just to genomic testing but to the associated precision medicines, the development of the whole workforce, not just the specialist workforce, and especially in primary care, and really outlining the role that primary care will play in the future, and there's lots of opportunities. And then finally, the number of precision medicines that are coming down the pipeline that all require genomic target testing to be done, and we'll need to be on the front foot to make sure that we can plan for that, and we've got the investment to support that. So thank you, Richard.
Thank you very much. So I'm going to open up for comments and questions. I mean, we're world leading, it's transformational, it's evidence of innovation, and then there's always going to be a question of prioritisation and resourcing, but we are in a really good position. For me, it's one of the delights of this role, actually, when I was introduced to this. I'm not a scientist, I'm not medical, I don't really understand it very well, but actually all I can tell you is the energy behind it, the progress we've seen, and the potential for it are quite remarkable, actually. So thank you. So let's go around. So we'll go, can I come this way around? I'll go Robert, then you will. So Robert first.
Yeah, a couple of comments and then a question, Sue. So, I mean, the first comment is congratulations on what you do in leading this. I think it is something nationally we should be very proud of, as you've quite rightly said. I would imagine people around the table know just what a dramatic acceleration this whole field has seen. Just to remind you, the first human genome sequence was 2003, so 20 years ago. It took about 13 years, cost $3 billion. Now it costs a few £100, and you can do it in hours. So the pace of change is quite extraordinary. The second comment I was going to make, and you refer to it at the end, Sue, about multi-omics, and that's where we need to get. So that's combining genomics with proteomics with clinical data and so on. UK Biobank is just a fantastic illustration as how powerful that is in getting insights into disease. So I think that's absolutely the right way to go. My question for you is, how long do you think it'll be before we sequence every newborn?
Sequence every newborn. Yeah, good question, Sue. Well?
So again, sorry to be dull about this, and I do agree with Robert's comments about the extraordinary work being done in this area. There's a sort of foundational element that needs to be put in place to achieve some of the futurist stuff you were talking about, and it really rests on data and digital infrastructure. And it'd be really interesting to understand where are we now in your view, and what do we need to put in place going forward?
And then if you can batch the questions. So Vin, I think you were going to comment or ask a question.
Yeah, thank you, Richard. So firstly, can I just say, without wishing to be obsequious, can I just acknowledge the personal role you've played in championing genomics during your time as chair? You've very much taken that.
Don't ask me to explain it, though.
No, but you have. The second thing I think is there are going to be three things that are going to completely transform healthcare in the years to come. One is genomics, one is AI, and one is automation. And so as we look ahead as a board to what's going to come down the line, those are the three areas we should pay a lot of attention to. An area that I think Sue hasn't talked about as well is that the UK genomics industry is also world leading. So the turnover of the UK genomics companies is 2.4 billion, market capitalisation is 5 billion, and it's got the fastest compound growth rate of many other industries when you compare it to the rest of the world. So I think when the government's talking about growth being its number one priority area, and we know the future of the health service is tied to growth, actually investment and the work that Sue's done puts us in a strong position as a way that we actively contribute to growth. And I think the way in which we've done that, which should be a template actually for the way we think about the future of health, which I think Sue's paper illustrates, is the way that basic science research, education, innovation, service delivery and data are all linked up with each other. So there's a comprehensive service, and those are all the ingredients that you need to create really great services. And actually that is a template in the way you might look at a ICB or the way you might look at a region. It's the way we should think about health going into the future. So just to finish up on the data and the answers to the question. So firstly, I think good work is being done. We've got fantastic world-class data assets like UK Biobank. We've got growing areas like Our Future Health, our secure data environments, and the Unified Genomics Record that Sue and the team are working with mine to develop, and also to talk to government about in the spending review. But I think it's also true that one of our major gaps is the poor digital maturity of the core NHS itself. Yeah. And Lord Darcy called that out in his report about underinvestment in technology, and that will be a challenge. Lack of interoperability between primary and secondary care and genomics record is cited by clinicians as being one of the major barriers to interoperability, and it's one of the major causes of friction between primary and secondary care. And so this is going to be a major area for transformation. It's amazing work that Sue's done, but actually the underlying poor technical infrastructure of the NHS, I think, will be a challenge if we're to remain world leading in this area.
So I mean, Vin's probably mainly answered the question on data. But you may have some reflection on that, and then there's Robert's question as well about when will we be sequencing all newborns, as a sort of a question for your level of aspiration and ambition.
Yes, thank you. Just in terms of the data and digital, there's no doubt about it that there's a variability in digital maturity across the NHS. I think some of the ways that we're working in the genomic medicine service means that some of the work can be done outside of that without the level of digital development that needs to happen. Some of this is about lining up pathology systems better that we need to work on. We're also starting to work with global organisations on the adoption of some important standards for genomics into EPR systems, and that will be a game changer actually in this area. But the Unified Genomic Record will enable us to provide data from multiple sources, including research and also for clinical trial purposes and population health. The second question, the first question from Robert was about newborn sequencing. I think there will be another 2 years for the generation study. That will be really important in understanding the impact, not just for the disease they're looking at now, but the diseases that are in the research environment at the moment. I think as we come out of that will give us the evidence, hopefully, because of the impact, the understanding of the impact on sequencing. I would like to think I'm very aspirational, not just for newborn sequencing, but also in conjunction with Genomics England, how we look at adult population genome testing, potentially in conjunction with the NHS health test. And particularly that would give us an opportunity to introduce pharmacogenomic profiles and look for diseases of a genomic origin, not just monogenic, Robert, that you know, but polygenic, that occur in the adult population. And I think finally, this whole coming together, this requirement to automate, we set out in the paper. Our laboratories have got to now change fundamentally to industrialise and automate, to really drive efficiency and productivity and meet the demand. It's not going to be more about putting more money in and expecting more out. We have to do things fundamentally differently, and also use artificial intelligence, hence why we have a network of excellence that's focusing on what can be applied and what gains we can get from applying AI.
Very good. So Sue, thank you very much, and thank you for your leadership in this space. And I think it is transformational and innovative, and it's part of the future of medicine, actually. So thank you very much for what you do. So let's go on to the last substantive item. I'm not in any way demeaning the last item, which is the delegation of the commissioning functions, which is a long-running programme and process of delegation out into the ICBs. But Amanda, can we pick up with Tom on the frailty pathway?
Thank you. People have got the short paper. Essentially, as the population ages, the numbers of people who are suffering from multiple long-term conditions and consequent extreme frailty is increasing, and therefore the proportion of healthcare resource that we use on this relatively small but very frail cohort of people is increasing significantly, and that's largely due to increasing urgent acute activity, so hospital stays for largely elderly, very frail people, and not only do we use a significant amount of our resource in this way, but actually we're not spending that resource in an effective way to give those patients either a good experience of care or the best possible outcomes. And in fact, for many of those patients, prolonged stays in hospitals actually mean their overall condition worsens and reduces their ability to live independently at home. And so we're spending a lot of money on not serving well a very vulnerable proportion of our population who are very frail. And what we are updating the board on here is the steps we are taking to offer more coordinated, better care and support to those patients, largely in their own home or in the community.
Thank you. We can assume it's a quite brief paper to raise it. Tom, do you want to say anything by way of introduction before we open to any comments or questions? Okay, so we had an earlier discussion at the private board on a sort of slightly longer paper attaching to this topic. So comments or questions for Amanda or Tom? I mean, if I open, from my perspective, and I'm perfectly content to be completely wrong, but if it were me, this would be not because of the return on investment point, because I can sense from both sides of the table there'll be probably disagreement about what you invest in for the longer term return. And from an old banking perspective, that's often the difference between the net present value and the cash profile. So actually it's what's the upfront investment for a long positive NPV. That's fine as long as you've got the available cash profile to invest. So I think that return on investment's a really strong one. I don't think about this like that. I think about this in terms of just how our capacity is being utilised. So it's a relatively small cohort of the population, but as you said in your introductory remarks, it's a very intensive user, particularly of our acute care, but actually more broadly. So I think it's a really, really important topic. Other comments, other questions, other thoughts about how we engage? Robert?
Just a simple one. In paragraph 7, you talk about system partners will be provided with facilitation support and robust evaluation. The evaluation is obviously crucial if we're going to learn what we want to learn. I wondered, this is really health services research territory, whether the NIHR ARCs are getting engaged with this. They would seem to be a logical source of evaluation skills, but my question is who's going to do the evaluation?
So we don't have an answer for that yet. This is paragraph 7 refers to the neighbourhood health implementation programme, which is part of our commitment to develop a neighbourhood health service, shift activity and resource out of acute into primary and community services and focus on prevention. This is a key part of the initial stages of that work, but we haven't completed the design of the programme and haven't yet agreed who'll do the evaluation.
So I would lean heavily on NIHR and the ARCs to do so.
Because if we're going to shift out of acute into community, and 3/4 of our beds are currently occupied. So 74% of bed occupancy is people over 65, and 25% of beds are people with dementia. As I said in the morning's conversation, almost half of whom are initiated into the acute hospital because of a UTI or chest infection is our national level stats, and those two conditions don't need to be treated in hospital. It doesn't mean all of those people shouldn't be in hospital for other reasons, but the trigger of them going into hospital is a UTI or chest infection. And if we want to shift capacity and shift therefore resource into the community, and this is the population that largely occupies that capacity, that's why I think it's sort of like it's an industrial question about how do we do it, and are there some do you think there's some quick win interventions that can emerge within the neighbourhood team structure that could accelerate that?
So we've got, and Tom may be able to talk, but we've got lots and lots of examples of real
good practice.
Work that's really good practice, that's really delivering what we need to see. What we're not seeing is anywhere that's consistently delivering all the components well. And so this is back to finding good practice, scaling it up and spreading, and particularly for the sites which we want to work intensively as part of this programme, the learning and evidence sites, really seeing what it takes to put all of the components in at some pace and evaluate what difference that makes. And some of this stuff is here now. The ability to treat those patients at home exists now.
Jane, and then Wal.
Thanks. I mean, really, just to that last point, I mean, I think the next time we sort of come back to look at this work, it would be really interesting to understand what those timescales are in that test and learn environment. I mentioned earlier that encouragement to public services to take risks, innovate, etc. So it'd just be really good to get a handle on what that looks like, what that potential for stepping up is when we find things that are really working, and I think for all of us to just understand what that looks like. Yeah, thank you.
And what?
And my point is just again, I made it earlier this morning, but I think it's really important. Is when you come up with that plan, the timeline Jane's talking about, is around how you're going to work with the private sector. 385,000 beds that are in the private sector that are occupied by elderly people compared to our, 17,000, 20,000. So there's got to be connectivity there in predicting what demand's coming at you and why and when, and all the learning you can get from that. So I strongly urge you to figure out a way of using digital data. I'm coming back to the same boring stuff again, but it's foundational in order to drive improvement.
So do you want to...
I just think you're absolutely right, Wal, and I think the important thing we have to recognise is we will never support and care for this cohort of the population unless we work with social care and the care sector, both care homes, domiciliary care, but also some of the wider independent contractor services, pharmacy services, medicine services, diagnostics, voluntary, community and faith sector who provide human rights support. So the benefits of taking this neighbourhood health service approach is about being able to work across sectors to coordinate the way in which we offer care.
Andrew?
It can be really, really effective. I mean, Claire, you work in my old system, and as a GP, if you come across a patient that you know needs help but doesn't necessarily need admission, you make one call, you get an assessment done on the day, you get access to social care, you get access to physio support, access to a geriatrician. It's superb, and it's reduced the work going into the acute sector, and it's one of the best things that I think the local leadership has done in that part of the world.
So that's Surrey Heart?
No,
that's
Fabulous Frimley.
Fabulous Frimley,
but used to run Surrey Heartlands, yes.
Okay, and also actually last week, Sandwell, the Frailty initiative in Sandwell is remarkable. The Jean Bishop Centre we talk about a lot, don't we, in Hull. Sussex ICB on Monday, to pick up Robert's idea about demonstrators. They'd be very keen to be a demonstrator ICB around this area if we were going to choose 2 or 3 ICBs to suddenly intensely roll out programmes.
Briefly, I just wanted to make it clear how closely Amanda and I work together on actually implementing some of the things. So it's often, we've talking about UEC and this as like they're sort of separate things, but when we are supporting particularly challenged systems, we work really closely with the Frailty team and people who've got expertise, and we will often, we arrive in the acute setting, but we know the solutions are here. So some of the sort of, I think, challenges we get in are, this is really good stuff, how are we doing everything we possibly can to ensure delivery? So we've got some universal approaches to it, we've got some targeted approaches to it, and absolutely where we know we've got problems of hospital capacity and utilisation, this is the top of our toolkit in terms of the way we work with systems, and we use lots of the examples that colleagues have said around this table to show what's possible, and I think we're getting better at the economics of that as well. So what it takes to be able to free up resource, to be able to invest in the service, to have the confidence. I think you've seen some of those models when you've gone on visits.
Mary, did you want to comment?
Yes, I just wanted to say that many of the people who are elderly and frail actually don't want to go to hospital. Yeah. So actually, if we get this right, it's about patient choice. It's not all being driven by economics. I think it's quite important to just recognise that.
Yeah. So, any other comments or questions? If not, Tom, thank you for coming, and thank you for all you do as the National Clinical Director. And Amanda, thank you very much. Very good.
You can let them respond.
Final words. Oh, yes, sorry. Do you want to... I thought that was just a comment rather... you want to comment? Would you like to comment on that, or anything else you've heard, Tom?
I think the final point is a really important one. What matters to older people living with frailty is predominantly independence, being at home with family, and it's so much not about unnecessary hospitalisation. There's a lot of opportunity. We're hearing about all the innovation going across the country. We need to systematise that and support, because there is a very clear evidence base in this area. However, we can codify that, but the context is crucial. So the way that evidence base is implemented, we're going to provide support to form hopefully effective neighbourhood frailty teams.
Great.
And it will need to partner, won't it, broadly in local authorities and with communities and voluntary sector, things like isolation and so on, to get older people away from that environment.
Primary care, social care, VCSE sector all have to be involved.
Yeah, very good. Thank you very much. So thank you for that. I'm going to move us on just to the last item. So Steve, it's for you. It's a delegation of further delegation of commissioning functions, so vaccination, screening and CHIS.
Yeah. Thanks, Richard. I'll take the paper as read, so just try and cover a couple of points. So the board's being asked to approve the proposals in the paper, and I just want to sort of add a little caveat to that, which is, in effect, this is not the last decision the board will take.
No.
There's still some stuff to work through, and it'll be subject to a final decision, which you'll be very familiar with, having done that with specialised commissioning. So a very brief point on the why around this, which is really important. So you've heard me say this before, vaccination and screening sit very firmly in the population health improvement prevention space. Vaccination is the second most effective public health intervention to clean water. The screening programmes in England save 10,000 lives every single year. And that's great, and we know that we can do more. And the reason that we have come to the proposal to delegate the vast majority of vaccination and screening services to integrated care boards is prevention and improving population health sit firmly as one of the key purposes of ICBs, and actually these sorts of services should be integrated into all of the other work that ICBs are doing in this space. I think it's important to say these will continue to be national services. They are consistent services across the country. They follow advice of the Joint Committee on Vaccination and Immunisation or the UK National Screening Committee, and that will continue to be the case. The thing that will vary across the country is how the delivery of them works. So the really hyper-local stuff, by which we mean exactly what Amanda's been talking about, actually. So where do you locate the services? How do you connect with communities to build trust and confidence? And that's what we want ICBs to focus on. So the kind of delivery end of it, the delivery model. You'll see in the paper that we are going to retain some services nationally or some functions nationally. So that's the technology and the data platforms which will be available for the country to use, and some functions of screening that we think we should retain for purposes of scale. And you'll see those in the appendix. So, for example, commissioning of the provider who sends out the fit kits in the bowel cancer screening program. It doesn't make sense to delegate that because we do it once on behalf of the country. There are some issues that we just need to explore in the context of some of those services and functions that will retain, particularly around bowel cancer screening and cervical labs. So we'll continue to work on those areas over the course of the coming months. I don't think there are any showstoppers in there, but there's some things that we just need to complete our work on. So in terms of sort of next steps, we've already been working closely with ICBs, or rather our regional colleagues have, to consider the right way in which to delegate services. We'll continue to do that over the next quarter. As I said, answer some of the outstanding questions that we've got. There's some work to do around both the HR process and how we will manage the delegation of the budget to ICBs. But again, very familiar territory in terms of what we've already done around specialised commissioning. The delegation will be subject to the usual readiness assessments. They'll come back to the board at the right point. But importantly, you'll see in the paper, we're proposing delegation from the 1st of April 2026. In reality, ICBs are really interested in this area and have been leaning into it for some time, actually. So the paper just sets out that We will continue closer working with integrated care boards in 25-26. We're not going to do a big legal agreement or anything like that, but we will work in a different way so ICBs feel like we are supporting them in the discharge of a function that they have a stake in. So we'll still be responsible for it and we'll be making the decisions, but we'll do that in concert with ICBs so that it is a bit more joined up. That's all I think I was going to draw the board's attention to.
I have one question and then I'd like to draw out one thing. Let me draw the point out first. First of all, for the board, as we consider it, this is wholly consistent with the delegation further devolution out into ICBs, which I think is a hugely sensible rewiring of the way the NHS operates. And also just the board would have seen that these proposals would have been considered by the Vaccination Screening Delivery and Transformation Board, by the Commissioning Development Delivery Group, and also by the NHS executive. So it comes to us having sort of been scrubbed essentially by three different groups. That said, the only question I've got, which I couldn't really pick up, I'm probably reading it too fast actually, apologies. As we're now moving to a removal of the ring fence, not removal completely, but we're reducing the number of ring fences. As we allocate these out, will these remain ring fenced effectively in the ICBs?
Do you want me to have the first go at that, Julian, then you? So we haven't come to a final conclusion on that. We want to make sure that ICBs have got flexibility, and actually there are some arguments. Colleagues will often say we should ring fence this to make sure it's preserved in the public health arena. And I understand that. And there are also counter arguments to that, because ICBs have large amounts of resources allocated to them. We allocate money for health inequalities and so on. So there's a bit about joining all of that.
So will you determine that before we go in?
What we'll be doing is setting an outcomes framework as part of the delegation agreement. And I'd rather do that and get agreement from ICBs on the outcomes and then really leave them to manage how they do the resources, resource allocation rather. The only thing just to quickly say, Richard, is historically the public health Section 7A grant, as it were, was ring-fenced when it was delegated to NHS England. It hasn't been ring-fenced for a couple of years, so just a point of clarity on that.
Okay, thank you. So is the board, any other questions, or is the board comfortable to approve the proposal?
Makes total sense.
Thank you very much. Very good. So let me just quickly go around. Is there any other business before I close? Any other business from anybody? Okay, well, thank you. Well, first of all, can I just thank the board? We've been going actually with about an 18-minute lunch break since 9 o'clock this morning. So thank you very much for your diligence and attention and, as always, contribution. And also, can I just finish by thanking again Wal and Andrew. We will miss you. Well, we may not miss you, but we will. we will miss you. So thank you very much for all that you've done. That closes the board. Thank you.